So, good evening and thanks to everyone for joining us today. We welcome you to the webinar today organized by Haryana chapter of ISAR, and the technical partners for this webinar series is Jagsonpal Pharma, makers of Endorec, Divatron and Injection Maintain. We present to you Endorec micronized Dynogest 2 mg in endometriosis associated pelvic pain during IVF procedures with calendar therapy pack. We have Divatron 10 mg micronized tablets of dydrogesterone to improve compliance and enhance outcome. We have Injection Maintain 250 and 500 mg of 17 alpha hydroxy progesterone caproate to maintain positive pregnancy outcome. A warm and hearty welcome to all the esteemed faculty and attendees. Please note this webinar is streaming live on Facebook and the link has been shared in the chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. Now we invite Dr. Jyoti Malik, Chairperson, Haryana Chapter ISAR and Director, Root IVF at JJ Institute of Medical Services, Bahadurgarh, to kindly initiate the program. Over to you, ma'am.
Yeah, thank you so much, Nimisha. Thank you, Jagsonpal. And this is our Inspire Ignite series number 15. And I, with my team, ISAR Haryana, with the Secretary, Dr. Meenu Handa, with Clinical Secretary, Dr. Manju, and Treasurer, Dr. Lakshmi, bring to you on this platform yet another series. And today we are talking on endometriosis, how to deal with it. And this is with our tagline from ISAR Haryana, Prayas Evam Vistar. We bring these regular once a month feature, and with the support and with the guidance of our National ISAR President, Dr. Amit Patki sir. So Dr. Amit sir is Medical Director, Fertility Associates, Mumbai, and he is Honorary Associate Professor, Somaya Medical College and Hospital, and also Khar Hinduja and Surya Hospitals. Sir has 35 publications in various national and international journals and 50 book chapters and 2 international patents in infertility and stem cell research. He is a TEDx speaker as well. Then we have our Secretary General of the National ISAR, Dr. Asha Bakshi ma'am, who is always there supporting us, guiding us, and always there at whatever point we need her support or advice, she is there for us. Dr. Asha Bakshi is Honorary Secretary General, as I said, and she is the lead consultant at Asha Bakshi Fertility Center in association with Motherhood Hospital, Indore. She has been the Vice President of West Zone Foxy in 2022, and she is founder chapter of the MP IAGE and MP ISAR. So today now we go on to our scientific session where we have our chairpersons, for this session, we have Dr. Poonam Lumba. She is the founder chairperson of the ISAR Haryana. Then we have Dr. Gurneesh Singh, who is the president of the Hisar Robs Gynae Society. Dr. Lakshmi Goyal, our treasurer, and Dr. Sonam Sachdeva, another senior practitioner at Karnal. And we have can I have the slide, PPT slide of Dr. NM sir? So we have a brilliant, I think, a speaker, a person who makes things seem so very easy by his talk that if you listen to him, things become so very simple. A dynamic person, a speaker par excellence, and we can see the CV that is being presented here. It is I think it would take an hour to go through the CV. Sir is the director, managing director, Global Rainbow Healthcare, ART Rainbow IVF, Foxy Smriti Manyata, and directors of so many, I think, medical, so many these ISAR, ISPAT, IFOM, Foxy, AOGS, ICMU, and founder, editor of the CEFOG journal. So, editor of so many books, so many papers, and whenever wherever there is any paper that we talk of from the Indian context, I think it is always Sir who is there in any particular subject, any particular topic that we look in for. So, and today he is going to talk on the medical management of endometriosis, what's new. And over to you, sir, so that we can again get something new from this old topic.
A very good evening to all of you. It's indeed a pleasure to be here with Haryana ISAR once again and to talk on endometriosis. Now, let me just, before going on straight away to the drugs or whatever we have, we'll just try to solve some of the physiopathology, etiology, so we understand how these drugs will work. The first thing we must understand, endometriosis is an enigma. And when something is an enigma, that means you can't understand it. And if you can't understand, you can't treat it. So enigma is something you can't understand or can't explain. And that is what makes this endometriosis a very challenging, enigmatic, and a very elusive disease. This is a painting of a woman in pain done by the Endometriosis Awareness Art Association, which is trying its best to make people aware of what this disease is. We have been working on endometriosis since 2008. And in 2018, this Foxy focus on endometriosis came out under the presidentship of Dr. Jaideep, 2018, not 8. And very recently, we come out with the Endometriosis and Enigma, a book just last year or probably this year in the managing committee at Delhi. So this solves all your recent things and is worth reading both of them. Let's see the scenario. 1 in 15 women, reproductive age group, cause not known, not clear, how we can prevent, not known how to predict this disease, no simple test, not even an operation sometimes can diagnose, and there are at least 4 treatment options, none better than each other. Welcome to the world of endometriosis. About 25% of women in their reproductive age group from adolescent to menopause will have this disease, which will be dysmenorrhea, dyspareunia, infertility in the reproductive. This is the world of endometriosis. All over the world, the incidence is now almost same. So when we look at it, the age when a girl comes for the first consultation of the symptoms, 10 to 9, about 20 to 29, about 46%, 30 to 39, 31%, and later age group, 7%. So this is how the pain is distributed. 5 to 15% of reproductive age group and 50% of the women with endometriosis are infertile. It's a lifelong journey now this journey, when the menstruation is painful, people ignore it, give painkillers, pain worsens, the pain continues, finally they'll end up with a consultant OBGYN after almost 6 years of this disease being treated by common healthcare professionals, homeopaths, Ayurveds, or whoever, or self. So ESHRE came out with a guideline on which in 2022, and this practice guideline was also worth reading, which is all going to tell you how you should go about endometriosis, and which is very, very important to follow some guidelines. Now, firstly, what is this? So it is a non-neoplastic growth of endometrium, which is present outside the uterus, which is similar to the endometrium, it is invasive but non-plastic. So it's often painful condition, and it is the tissue acts as a lining, which is inside. It's coming now outside and settling on the ovaries, peritoneum, everywhere. Why it happens is very, very, there are a lot of theories. What it will cause? It will cause pain, it will cause bowel movement, it will cause urination problems, it will cause heavy menstrual bleeding, it will cause indigestion, diarrhea, constipation, fatigue, and infertility. Who are at risk? Those who with high estrogen. Now, these are important because our treatment is going to be aimed against this. There's genetic predisposition. We cannot change the genes, so we need to change the epigenetics so these bad genes don't work on it. Patients with Mullerian anomalies and the patient who have high risk of retrograde menstruation, where their menstrual cycle is prolonged of more than 5 days, or who have a shorter menstrual cycle. These are the ones who are more prone to this disease. Now, what happens? You see the yellow, the dotted, and the green. The yellows are the initiating factors. So transformation, retrograde menstruation, coelomic metaplasia, embryonic remnants. Now, these are the etiology. The dotted line is the propagating factors. Hormones, estrogen, apoptosis suppression, immune dysfunction, oxidative stress, lymphatic dissemination. And green are the predisposing factors, the genetics and the flow obstruction. Now, when we understand this, our treatment is going to be against the hormones, try to prevent the apoptosis, try to improve the immunity, try to reduce the oxidative stress, try to do something about the vascular dissemination, and of course, we cannot do about the genetics or the embryonic remnants. Now, this all can cause superficial or deep endometriosis. So the etiology is complex and multifactorial. Retrograde menstruation, coelomic metaplasia, metastasis, stem cell hormone, altered gut dysbiosis, so decreased immune response, and chronic inflammation is the basis. That's very important. So we're going to work or have a medicine against chronic inflammation also. The role of estrogen is very important because estrogen causes proliferation of this utopic endometrium, that is normal endometrium in the uterus, and ectopic endometrium, which is outside the uterus. So estrogen-dependent disease, which will lead to growth and proliferation, which will also lead to pro-inflammatory effect, which will also lead to vasculogenesis and neurogenesis, causing severe pain and the others. So what happens? There is a hormonal dysregulation. In the normal, you have the estrogens, you have the estrogen alpha and beta receptors, which are in balance. And accordingly, when the estrogen is at level, the progesterone receptors are expressed, and that will suppress and cause menstrual bleeding. When there is endometriosis, there is an estrogen dominance, and this conversion or expression of progesterone receptors is not there, or even if there is progesterone resistance. Hence, that leads to increased estrogen. So estrogen dominance is present in patients due to local aromatase, progesterone resistance, hormonal imbalance, oxidative stress, xenoestrogens, or what we call as the EDCs, micronutrient deficiencies, gut dysfunction, melatonin dysfunction. And this will lead to high estrogen, and high estrogen will lead to endometriosis. So estrogen works on the normal endometrium and works on the endometrium which is in the peritoneum, and in the peritoneum, these endometrial cells, usually the immune cells will eat up these endometrial cells and do not cause anything. They'll be removed, but women with reduced immunity, there'll be invasion and angiogenesis, implants will form, chronic inflammation will occur, adhesions will occur. Let's come to the role of progesterone. Again, very important because we're going to give progesterone drugs for treating. So we have two types of progesterone receptors, A and B. Now, in a healthy endometrium, the progesterone receptor B is more prominent, and this will respond to the cell proliferation, destigmatization, apoptosis, anti-inflammatory, anti-angiogenic, and menstruation. In the utopic endometrium, ectopic endometrium, which is outside the uterus, the progesterone receptor A is prominent, and that will cause reduction of all these. Hence, there will be more inflammation, more pain, more bleeding, and the destigmatization will not occur. So what happens? The antigen is the endometrial cells which leaks from the tubes into the peritoneum. That is the antigen that reaches the peritoneal cavity. It is destroyed by the immune system. If it is not destroyed, it expresses apoptosis. It stimulates a CD4 in the helper cells, which further destroy it. And if it does not, then subsequent menstrual cycle, the antigen goes and the response is more and more inflammation occurs. So chronic inflammation, damage to the cells of the peritoneum nearby, and sensitization of the normal self-antigen. So now the body does not recognize this. So there is immune suppression. So estrogen formation, prostaglandin, progesterone resistance, leading to inflammation and endometriosis. Now, one more thing to remember before we come to the drugs now is the estrogen threshold theory. Now, women need estrogen because estrogen, if it is hypoestrogen, they'll have osteoporosis. So the optimum range where the endometrial lesion growth and bone loss are minimized. So if you don't, the endometrium does not grow and the bone is not lost, is when the estrogen levels are 30 to 50 micrograms. If it is less than that, then the bone will be osteoporotic. If it is more than that, the endometrial tissue or endometrial lesion will keep on growing wherever it is. So endometrial growth is there. So the mean estradiol levels with these drugs, whichever we are giving, Dynogest or whatever, should be around 40, 30 to 50. That is where the drug should suppress the estrogen, but not over suppress the estrogen. So clinically, depending on what the problem is, the treatment will be there. She may come with pain, dysmenorrhea, bowel, infertility, premenstrual pain, severe dysmenorrhea. So how do we manage? Before managing, we diagnose. So we have a ESHRE guideline diagnosis algorithm, which all of you can download and study, which is very, very simple. Symptoms, ultrasound, and the markers. The markers are not very important now and are not done routinely. We don't still have a test. The markers are non-invasive and invasive. The non-invasive is imaging, and the invasive is CA125, endometrial antibodies, endometrial aromatase enzyme assays, metrioic test, IL-6 test, and leptin test. These are not yet available. And of course, the invasive are the laparoscopy and laparotomy. So what treatment options we have and what are the guidelines? Now, it is an epiphenomena, it is an enigma, it is a benign cancer. So how does anyone treat an epiphenomena or benign cancer? That is the enigma. Our goal is the patient should be relieved of pain. We should try to slow down the growth of the endometrial tissue. We should improve her fertility, and we should prevent the disease from recurring. Please remember, there is no permanent cure for endometriosis. No single treatment is ideal for all the patients, and it will depend on our symptoms and depend on our needs. So if you're going to give suppression treatment, infertility will not be cured. If you're going to get infertility treatment, pain will not be suppressed. So that has it. So if it is pain, we go by NSAIDs, hormone, and the newer progestogens. If it is infertility, we go for tri-ovulation induction or do surgery or minimal assisted reproduction and or ART. If it is occurring in pregnancy, then the progesterone has to be there, because I told you the progesterone receptor pregnancy is a hyperprogesterone state. But still you can have endometriosis. If you do a cesarean section, if you're taking out the uterus, please look behind the uterus in all of them. And in 10, 12 out of 100, you'll see there are bleb lesions all over. That is pregnancy endometriosis. So we will plan a treatment for infertile group, for fertile group, which is mild, moderate, and severe, for recurrent endometriosis, for rectovaginal endometriosis, and for pregnancy endometriosis. Some people say do nothing, expectant treatment. Now, this is not, the disease is progressive. Then you have pharmacological treatment, and then you have surgical treatment of fulguration and ediolysis. We are not going to talk of surgical. Someone else will discuss this. Medical treatment should be the first line of treatment, or used after surgery, or when surgery is refused or surgery is not possible. And if you have to give medical treatment, you know that it is going to be a lifelong treatment for the management of pain till menopause. Even sometimes in perimenopause, the pain can come back. What are the drugs we have? We have NSAIDs, we have OCPs, we have androgenic agents, we have progesterones, progestogens, GnRH analogs, antiprogestrogens, oral antagonist, levonorgestrel IUCD, newer experimental drugs, and the other treatment like acupuncture, acupressure. So how do these fare? The first line of your treatment will be OCP or Dynogest. That's your first line. We want to induce hypoestrogenemia, but not that osteoporosis occur. And Dynogest is a good drug for this. The other drugs which are anti-progesterone or anti-estrogen or which are androgenic are danazole. Now, danazole should never be used. It was a second line of treatment because in the right dose danazole, which is very high, 200 milligram 4 times a day or 800 milligram total, their danazole will cause severe non-reversible hoarseness of voice and hair. And of course, we don't want a woman to have a voice like this. Women's voice should be sweet, not thick and hoarse. Danazole will cause permanent hoarseness of voice. So please don't use danazole at all and if you have to use it in the right dose. GnRH agonist is a good option, but can be given only for short term before ART because it will need a add-back estrogen after 6 months, otherwise it will cause severe. GnRH antagonists, the oral ones are the new ones, in which we'll also discuss a little bit about it. So agonist, Dynogest, levonorgestrel, OCPs, antagonist, and aromatase inhibitors are the experimental ones. How do these fare? What are the indications? OCPs will inhibit the HPO, cause headaches. Only progesterone, medroxyprogesterone or depot will inhibit the HPO axis, cause weight gain and depression. Dynogest, anti-androgenic, anti-proliferative, anti-angiogenic, very, very good drug, headache, breast discomfort. Danazole, not to be used. I'm not even going to talk about it. GnRH agonist, injectable, long-term, 3-monthly, inhibit the HPO, cause pseudomenopause, osteoporosis, vaginal dryness, sexual problems. Aromatase inhibitors, letrozole or anacetrozole, long-term, avoid aromatase-dependent increase in prostaglandin, so good for pain because they increase the COX-2 expression of estrogen, but they will cause hypoestrogenemia. GnRH antagonist, elagolix or relagolix, which is now available, will inhibit the HPO axis, cause pseudomenopause. It is safe, tolerable, but again, for younger girls, estrogen would be. SERMs or selective estrogen modulators, estrogen agonists, again, so they help in bone, prevent BMD, and no stimulation of the endometrium or the breast. So reversible elevation of liver enzymes. So liver has to be selective ERA and B agonist, which I showed you, ERA and B receptor of the estrogen. Now these drugs will come into market soon, anti-inflammatory and will be good for pain. Raloxifene is already there. Sperms or RU486, selective progesterone receptor modulator. Statins are good drugs and helpful for cardiovascular risk in perimenopausal women. TNFA alpha blockers will also be available and anti-inflammatory. Pentoxifylline inflammation modulator, insufficient data to use for all. VEGF, Atavestin, Nginx, endostatin, all these are now coming in the market and they inhibit the vascularization of it, but has not yet been tested in women with endometriosis. And of course, cabergoline, long-time cabergoline, daily cabergoline, reduce the neovascularization, but then they may cause. So to summarize, you have anti-angiogenic, statins, and ER ligaments. And these are the whole list of experimental drugs which are tried when nothing is working. Now, medical treatments are effective for reducing the pain, but unable to eradicate the disease. That we've already told you. Combinations of disease can fail and systemic side effects. What does Dynogest do? Now, Dynogest will work on the utopic and ectopic endometrium both. So it works on the endometrium inside the uterus and outside it. And it will reduce the cell proliferation, reduce bleeding, improves the cell and improves the uterine contractibility. So pain reduces, heavy menstrual bleeding reduces. That's it. Then we have the antagonist, which is now coming, elagolix. Elagolix is now coming into the market whereby many companies, and whether it works or not. So there are still long-term studies are not there, but again, a good drug to be used if pain is the main symptom. But be careful of the suppression of FSH. So it will suppress the estrogen level if you give it in the right dose. The right dose of elagolix is 200 milligram BD, and that will suppress the estrogen level to very less, that critical level less. If it is 150 OD, which is the maintenance dose, then it is probably all right. Or low dose estrogen will produce gentle suppression. So if you're going to use the starting dose, which is 200 BD, then add back therapy may be required. So the pain has to be managed according to where the endometriosis is. When we compare Dynagest and elagolix, we just told you that it is the estrogen suppression which we have. So if it's pain is the main symptoms, maybe the elagolix may work a little bit better. But if pain, HMB, and the others are, maybe Dynagest is. And Dynagest has very long-term studies. Elagolix still has to be studied. That's why this paper came out, that elagolix may not be all that glitters is gold. So this is how they compare within. Dynagest is 4th generation progestin. Elagolix is a GnRH antagonist, and pseudomenopause it is going to come. So that's how you compare. I am not saying use Dynagest to use. Both of the drugs are good. Use whatever is there. When you use antagonist, you now have a combination which will be soon available, which is elagolix 40 with estradiol and NET. So estrogen progesterone is added to the combination, and this would be a good option to use. And this elagolix, I think, is already being used in prostate cancer. So with antagonists, you have to think of giving add-back therapy. Now let's come to the interesting part. This is the normal drugs, medical. There are some experimental drugs. And are we going to try that? The first is DCA, dichloroacetate. Now this is a potential normal non-hormonal treatment. And the latest trial shows that it reduces the pain in a lot in this. And it has got only mild side effects of stomach. And this is what is it? The second is the medical cannabis. Medical cannabis bhang. Now India bhang is available freely at every corner of the road. And whether we're going to bhangify our patients to treat endometriosis, but this will give you a false relief of pain and a feeling of well-being. That's it. Then we have Femsite. Now this Femsite is a highly specific antibody that labels the endometriotic cell for clearance by the immune system. So immune system has forgotten how to identify these endometrial cells in the peritoneum. When you give Femsite, this will go and stick on those cells and it'll make them identifiable to the immune system. And the immune system, the self-immune system, will remove these cells and cause treatment. Then a huge new study of microbiome science. The microbiome is the most important thing in our body. The amount of good bugs and the good bacteria which live on us is unbelievable. And these have to be looked after. So a good bacteria, microbiome, gut health is very important. Then you have the Cure Me project. Cure Me project. Now, this Cure Me project is a unique biobank of organoid lines, and these organoid closely recapitulate the disease hallmarks and robustly expandable. And this probably, there are a lot of work being going on how this is going to be used. Then very interesting is these targeted nanoparticles. Now, these nanoparticles with heating efficacy. So when we give this nanoparticles, they will go and stick inside the tumor, like here, and then we subject them to a magnetic hyperthermia from both sides of the waves, and these explode. And they will explode the endometriotic cells. So that is it. Then endometriosis could be controlled by a monthly antibody injection. So monthly antibody injection is also on the way, and IL-8, MEY109, and it is being tried in monkeys, and placebo with every 4 to 6 months, 4 weeks, given for 6 months. Then you can go for acupuncture and acupressure. Acupressure and acupuncture are very effective ways of reducing backaches and the others. Then we have nutraceuticals. So your diet. So we have a special diet for endometriosis, and what is known as a 4-week endometriosis diet plan. The Mediterranean diet is going to help in reducing the discomfort. So the 4 weeks diet plan repeated every 3-4 months is what should be added to your and these dietary interventions appear to be very promising in treating the endometriosis. Now, when people cannot take diet, we have ready-made dietary supplements available. Now, these dietary supplements which are available, which could be used as nutritional intervention, can work. And here's one of them, which we have done a study on, which actually works. And this reduces the hormonal imbalance, oxidative stress, xenoestrogens, micronide deficiency, and improves the gut. So what does it have? It has all the herbal products, which is Shatavari and Ashwagandha mainly in it. And this has been shown to be proven to be helpful in this normalizing the hypothalamic pituitary ovarian axis if given in the right. Now, just giving a dash of satire or what we call as fairy dishing is not important. It has to be there. Then you have glutathione added to it. Now, glutathione is a known anti-inflammatory agent and improves the immunology. Then it has selenium added to it and all the micronutrients added to it. So accumulation of harmful estrogen metabolites in xenoestrogen are eliminated then because of probiotics, chelating agents, which is all in a combination. There are published multi-trial centric trials in center in Bareilly, Agra, Kolkata, Bombay, and New Delhi. And we have just published this, and it has been well accepted, and clinical results are very, very encouraging of over about 1,200 patients. So, ladies and gentlemen, you have convention therapy, and with the convention therapy, you must sure to be add nutritional therapy also. So, treatment decision to conclude has to be made integrated depending on individual, depending on the severity, depending on the location of the disease, depending on the desire of pregnancy, depending on the age of the patient, depending on the medical side effects, surgical complication, and of course the cost. So hit and miss management should not be tried just because the disease is elusive, just because it is slow, it is challenging, it is unthinkable. Prevention, recurrence will always occur, it's frustrating, and the complete elimination is the complete surgical treatment. There are a lot of social media posts. If you go on the social media, Instagram, you see many pictures of these girls and women who are proudly showing their laparoscopic scars and talking about endometriosis, and lots of that endometriosis helpline group, endometriosis groups, yellow ribbon groups, all of them are there. Lastly, remember, it is teamwork and it is not you. And as you can see in Foxy, we all sit and work as a team. And I can see some of these team members are listening to this webinar. So gynecologists, surgical, pain, psychotherapists, counselors, nurses, psychologists, nutritionists, patient support organizations, and non-traditional treatment teams. It is difficult to understand cancer. It is even more difficult to understand a benign cancer. And it is impossible to understand epiphenomena. And Sir William Osler, long back, said that he who knows endometriosis knows gynecology. It still is an enigma. We are still struggling with it and trying to understand the disease. Thank you very much for inviting me here. I give you greetings from my city of Taj. Thank you very much, Dr. Jyoti, for asking me to talk on this very elusive, enigmatic subject.
Sir, you're always amazing. You always bring so many food for thought. I mean, that is why we all love to have you on our platform every time. Over to our chairpersons, Dr. Gurneesh, Dr. Poonam Lumba, Dr. Lakshmi, Dr. Sonam, your comments, please. And then we'll take comment from our special guest, Dr. Narendra, ma'am.
Thank you, sir. It is always very nice to hear to you. I am listening to you for last 20 years, sir. Sir, just one small question. You say that for endometriosis, we should give multi-pronged strategies. That means pharmacological, surgical, as well as nutritional. Am I correct, sir?
Yes. Individualized. So it depends on what. If there is mild pain, no endometriomas, bigger size, nothing, adolescent girl, try medical treatment. Big endometriomas, deep infiltrating endometriosis, severe surgery followed by medical treatment. Nutritional and lifestyle will go along with all of them. So you have to balance where surgery is required, where medicine, surgery, medicine, that is the sandwich therapy is required, or where you're going to do only medical treatment. If it is small endometriomas and she's not getting pregnant by conventional treatment, straight away IVF. Don't try to do surgery for small endometrioma. Do oocyte retrievals and do all the oocyte freezing or the embryo freezing, and treat her medically, suppress the endometriosis, then do embryo transfer. So there are a lot of, you have to individualize it. I cannot say, oh, the same treatment will work for everyone.
Good evening, sir.
Good evening.
Good evening, sir. It was a really an exhaustive and wonderful talk. So I wanted to know about this nanoparticle therapy that you've talked about. So what is it? We have never heard
So
about it.
these are, these are all experimental. They are not yet in the market.
Right.
Nanoparticles will be injected intravenously,
Okay.
and they go and attack and sit on these inflammatory cells of endometriosis. They invade into the cell, and then you subject, and they are prone to magnetic heating. So then you do a high focus ultrasound, focus on those areas, endometrioma, I just say, or you're deep infiltrating it. So you focus the ultrasound beam there, it causes heating, magnetic, and that heating causes the busting of this nanoparticle. When the nanoparticle inside the cell will burst, the cell will get killed. So that is how it will work, hopefully.
And nanoparticles are getting attracted subjectively to the endometriotic cells.
Yes, specifically designed to attack only.
Specifically designed to attack the endometriotic.
This treatment will work for cancer therapies also.
Yeah,
So
I think they are working for the cancer therapies also.
Yes.
Basically, they started
Yes.
from there.
Good evening. Good evening, everyone.
Hello, Poonam.
Hello, Dr. Narendra. Hello, Jyoti.
Hello,
Yeah.
good evening, ma'am.
I'm listening to the talk. It was very, very enriching. Or as always, you have, I think, told everything in so much of detail. And practically speaking, I completely agree. And I would like to advise also that every patient brings a new sort of, thought in our mind how to treat. It's very difficult in books and in theories. It's very different, but practically when we come to treating endometriosis, it is like nothing less than cancer. And nanoparticles, I think in prostate cancer, they are already using it.
Yes. So they're using in cancer
So,
therapy, and they're going to try in endometriosis.
yeah, I'm thinking that maybe like ultrasonic treatment also, it may also be thoughtful to start for endometriosis, because it's basically how to burn the tissues.
Correct.
Yeah. So everything has to be individualized. And my comment is that please, in infertility along with endometriosis, we must think of ART as early as possible.
Absolutely right. No
Yeah.
sense of putting them on OCPs or Dynogest or antagonist for a long period of time. Acute
Yeah,
pain,
because
short treatment with GnRH injections, and take them for IVF.
Yeah, it really delays, and they really become hopeless, When you see them, you really can't do anything once they have undergone too many surgeries and taken too many medicines. Then sometimes they have to, this malignancy also overcomes. So it's very important. So thank you so much. It's very nice seeing everyone after a long time. Yeah.
Thank you,
Good
Dr.
times are
Poonam.
coming
Thank you
again.
for joining.
Thank you, Jyoti. You are lovely as ever. Thank you, Marinder.
Yeah. Poonam, I think taking your thought process forward now, I want to just few queries were there that we have to individualize the treatment, and they sometimes need multiple surgeries also. That's why we should not be doing too much early surgery. Now, Dr. Malhotra, you said something about balancing between size and the symptoms of the patient. Now, I have gotten a young patient of 19, 20 years of old. She just has the pain, and she was diagnosed as the endometriosis. She was put on Dinogest. She did not respond. She came to me, and I had put her on Elagolix now. Elagolix, so many companies are coming up with that. And she has responded to this treatment. For the last 3 months, she has not taken any pain tablets. Now, I am following her up by ultrasound also, because her endometrioma was, according to the whatever prevalent thought process of 5 centimeters, it was bigger than that. It is about 7 to 8 or 9 centimeters there. But the size has not increased for the last 3 months at all. Now, considering people are talking about malignant changes and all that, so I am also worried that I am taking her for conservative treatment, because her pain is cured now. She has a better health. She was relaxed, and she was doing her studies in a proper way, not the absenting themselves. So, can anyone guide now what should be the ultrasound finding which should alert me if there is no change? It's a simple endometrioma. You can make a multicystic. It's the mass is there. So the one is the 4 to 5 septations, and they're 4 to 5 centimeters. Another 2 or 3 to 3 centimeters only.
So the surgical
That continue.
guidelines for managing endometrioma is 5 centimeters, and severe
Yeah,
pain
but
not being relieved, and if a normal ovarian tissue is not seen around the endometrioma, because with pressure it is going to damage the normal ovary also. So you have to think of surgery at some stage or the other. Now you cannot give antagonists for more than 1 or 2 years because of osteoporosis, because of the young girl. So you have to add back estrogen. When you add
that
back
I'll be looking
estrogen,
into. I'll get
please
her
listen. No,
estrogen
please listen to
tested
the
out.
full thing. Then you come
Yeah.
or you speak. So you have to add back estrogen to counter the anti-hypoestrogenic effects, and that has a risk of the endometrioma growing again. Once you stop the antagonist, elagolix, the disease is going to start growing. So finally, because they are 5 centimeter plus, she is unmarried, ovary is likely to get damaged, do an AMH. If the AMH is getting compromised, please do surgery and conservative, and tell her for oocyte cryopreservation. So fertility saving tactics also have to be started in adolescence. So you stimulate and freeze her eggs. So egg freezing is medical egg freezing is an indication in this case.
Second is ovary is absolutely normal, and I can see the ovarian tissue in this ovary also.
Fine, continue
And
for 2 years. Continue for 2 years.
I think very good suggestion.
Continue for 2 years. When you
AMH
stop it,
is
then
very
you
good
see.
suggestion. So how long? 6 months I can continue safely.
2 years.
2 years I can continue.
200
Proper
milligram
follow.
BD for 200 milligram
I'm
BD for
giving
3
her
months,
just
and then
150.
150 BD for next 2 years. Add back estrogen may be required. Please do our estrogen level, BMD levels, AMH levels, estradiol levels.
BMD, AMH, I think we can do early. And estradiol levels, of course, should be done at 6 months, I feel. But we have to make some sort of guidelines also. What we should be.
Guidelines are there. Follow the
Individualization
X-ray
is
guidelines.
okay.
Follow the X-ray guidelines.
At that time, oral antagonists were not there.
But with the antagonist also, they've just released a guideline.
But that is the 5 centimeter only, I think.
5 centimeter surgery.
Yeah, Dr. Sonam, your comments, please.
Yes, it was a wonderful talk. I'm a big fan of Dr. Narendra Malhotra. And sir, it was fantastic talk. I just want to know a view about the patients. Do you recommend a course of antibiotics before putting them on any kind of Dynagest or Egalux for the long term?
Now, giving antibiotics is your personal choice. Because it's an inflammatory disease, if you do a routine test, yes, I hope you're doing CRP and all of them, the CRP will be highly raised. That will show you that the inflammation, how the level of it. So if there is inflammation or there are any other signs of PID, along with it, a course of empirical antibiotic is of no harm.
But because there were few papers who hold that infection, anaerobic infection is one of the reasons
Yes,
for
because it's very
endometriosis.
rich blood. So a course of antibiotic would be no harm at all.
Thank
So
you, sir.
one
One more
last,
question.
yeah, Dr. Mandy. Yes.
Yes, just one more question. Risk of torsion in these cases.
So because these endometriomas are from outside, so it is not intra-ovarian. Any ovarian cyst or ovarian tumor which is intra-ovarian is likely to torse. If it is coming from outside, the menstrual blood comes, sits on the ovarian surface, sits on the peritoneum, and then goes inside and forms. So there's going to be a likely adhesion to the peritoneum. I know some cases you see freely mobile endometriomas also. Those can torse, but usually there are some adhesions, and torsion can be there. I'm not saying it's not there, but is relatively lesser than simple cysts.
Okay.
So
Thank
one
you.
last question. Sir, what about your personal experience about Android that you spoken about
So
Shatavari, and
we have
that is
just
a 3-month course, and how long have you used it? How did you find it, the relief part and everything?
So we've just published this study, a multicentric study by 4 on 1,200 cases used for 3 months. But because it is a nutrition, it can be given lifelong. It is just your health. It improves your inflammation. It brings down your CRP. It gives you well-being. It gives you, it's like taking a supplement. So patient can continue lifelong.
And the results were quite good, the pain relief
Results,
and the...
pain relief and all is, see, it is not, I mean, there is no study with only Android versus GNR. It's like a nutritional supplement. So the drug plus Android. You
Right.
can't put them only on Android. Only Android is not a drug. It will not suppress the HPO axis. It will just regulate or improve the immunity of the normal woman. So it's not going to suppress, not going to bring the estrogen down. It's going to just regulate. So it has to be added to that. So it's an additive therapy. It's not a versus OCP versus, it's not there. That study cannot be done.
One
Right.
thing more for follow-up. Does CRP has a role to play, regular CRP?
CRP has a role of follow-up every year and everyone. Those
Every
who are
year?
normal also, even you must get a CRP every year. So you know how much inflammation is in your body. And say inflammation should reduce. If we are inflammatory in our body, we'll catch disease.
Right. Thank you so much, sir. It was amazing session, and a lot of discussion. Thank you, all the chairpersons. And now
Thank
we
you,
move
Dr.
on to the
Jyoti. I would like
surgical
to add a word about your experience on. I have a very good experience about Android.
Fast, jaldi se.
It's a fantastic molecule to reduce pain.
Okay.
Patients don't get
Okay.
dysmenorrhea if they're regularly on Android. The decrease in size is very slow, but definitely pain relief is excellent
Right.
without
So
any
more
other drug
Size
also.
won't be there with these medications, I think.
The future is nutraceuticals. So I just attended the World Nutraceutical Conference in Bombay, 2 days discussing only nutrition and the various things you have in nutrition. The Nutrify Today group you must join and
I think
listen to them.
probiotics also have a great role, that as you said.
Bilkul, that we told you, dysbiosis.
right. So moving
Thank
on
you.
now. Thank you so much, sir. Thank you. Thank you, chairpersons. Now we move on to our second session, where I would invite our next set of chairpersons, none other than Dr. Nisha Kapoor. Dr. Nisha is a renowned name, not only in Haryana, but I think pan-India when it comes to laparoscopic surgeries. And Dr. Nisha is our president of Haryana Association of Obs and Gynae, and also of Haryana Association of Gynec Endoscopist, IAGE chapter of Haryana. Then we have our second chairperson, Dr. Rakhi Malhotra. I don't think she is joined. I couldn't see her, but she is our vice chairperson of Haryana chapter. And then our rest of the two chairpersons also, Dr. Jatindra and Dr. Shweta, are, I think, yet to join. Can I have the CV of our speaker, Dr. Sujal Atul Munshi? So enough has been spoken about medical part, and now we have a fantastic lab surgeon, Dr. Sujal Munshi, who is MD at Kalpana Munshi Hospital and also a consultant obs and gynecologist at the Munshi Hospitals and Bankers IVF. He is honorary secretary of IAGE presently, and he has been the executive committee member, Children University, Gandhinagar, executive member, Department of Human Genetics, Gujarat University, and chairman of the Healthcare Task Force, Gujarat Chamber of Commerce. He is chief faculty for FOGSI, IAGE, and ICOG approved trainings at KMH LLP. So over to Dr. Sujal now, and Dr. Sujal would be talking on the surgical management of endometriosis. How far should you go? So that is, another very interesting talk. And over to Dr. Sujal now. Thank you.
Thank you, Dr. Jyoti Malik, for kind words, and I'm especially thankful to ISAR Chapter Haryana for considering this, especially getting a topic on surgery in Infertility Association. So I'll have to be very careful, and let us discuss what things we should be careful about. So because of social media, because of interest in the literature, we come across so many cases of endometriosis. So out of curiosity, someone has done really a paper that is the endometriosis becoming more severe, or is it becoming more prevalent? And in that interesting finding, they came across that yes, there is apparent increase in the severity as well as prevalence. But if you look at the literature, most of the literature is not uniform. There was so much of heterogeneity in the inclusion and diagnostic criteria. There was selection bias involved. So they concluded that it is difficult to conclude anything from the track record of 30 years, but we all know that because of the early investigations, because of the interventions, we come across more and more cases of endometriosis at young age. We have started seeing endometriosis in adolescents also. So the trend is definitely changing. So what happens? Is there a role of endoscopy? We see wonderful lecture by Dr. Narendra Malhotra sir that there are so many options for medical treatment. And before considering surgery, you should be very, very, very sure whether it is absolutely required or not. And then there are very few indications now left for endoscopy or minimal invasive surgery for endometriosis. So all symptomatic patients where symptoms are not relieved by medical treatment, or the medical treatment does not suit to the patient. Second is severe fertility issues where your medical management has failed, and there are genuine indications as per guidelines. Sir suggested the ASHRAE guidelines that patient fits into the category of fertility requiring surgery. And if the vital organs are getting involved because of the compression fibrosis like GI or urinary tract, ureter or bladder involvement, in all such cases, there is a role of endoscopy, there is a role of minimal invasive surgery and surgical management. Now, which are the areas of concern when we deal with the minimal invasive surgery? The main area is ovary, because in 80% of the cases, the pathology starts from ovary, endometrioma. Then now we get more and more cases of deep infiltrative endometriosis, which involves GI tract, ureter, bladder, and vascular compartment. So this disease has grown beyond the peritoneal boundaries, and this specific category is known as DIE, where there is very less role of medical therapy and surgical intervention is required. And third category is adenomyoma and adenomyosis. This is a real gray zone, especially when we are dealing with infertility, whether to operate, not to operate, and what to do is a dilemma. So we'll try to address it in further slides. So now it has been proved beyond doubt for past 1 decade plus that any surgery on ovary adversely affects the ovarian reserve. Though there are few scattered studies where very senior gynecologists or endoscopic surgeons have performed the surgery very meticulously. Few have minimized the use of electrocautery, few have used vasopressin injection, few have used dissection techniques by which they have been very careful in preserving the ovarian stroma, and they have come to a conclusion that if meticulously surgeries are being done, the clinical pregnancy rate and live birth rate are maintained after surgery also. But in rest majority of the studies, the ovulation rate, the markers of ovarian reserve, and response to the stimulation has grossly declined after any surgery on the ovary. So think twice, thrice, or more times before posting a infertile patient for endometriosis surgery. Very rightly said by our previous speaker that any lesion less than 5 centimeters, any small recurrent lesions may not require surgery. You have lot of options. Give short-term GnRH, control it, retrieve the eggs, form embryos, then you can do whatever for the symptoms. Laparoscopic cystectomy, when required, is ideal treatment. Do not just aspirate and leave. Follow all surgical principles, but remove the cyst completely whenever you go for a surgery. Here, it was written in bold letter in this very interesting study published recently in 2017 only, that surgeons' skill set plays a large role in impact of cystectomy for ovarian reserve. As I have said, there are few high risk factors like bilateral cyst, very large cyst, more than 5 to 7 centimeters, and the technique, they can grossly adversely affect the ovarian reserve. So technique is very important, and selection of patient is also equally important, especially for infertile patients. Continuing in the same study, not all studies show a correlation between low AMH and low pregnancy rate. So apparently after surgery, if immediately AMH is being done, you may be under false impression that lot of ovarian reserve has been damaged. But if proper time is given to recover the ovary in form of GnRH analog or some medical therapy, it has been shown that recovery of the ovarian reserve has also been noted over long-term follow-up. So this is to be kept in mind, that don't get your ovarian reserve checked immediately after the surgery. After surgery, give some suppression medically if required. Do your recovery, monitor your recovery part, and then go ahead with ART or whatever therapy is required. So if you do this, cystectomy still has some role in selected patients, and whenever it is to be done, it has to be done with proper surgical principles, and a complete cystectomy is required, and surgeon should implement ovarian sparing technique. So use of vasopressin, use of hydrodissection, avoid using too much of cautery should be kept in mind while doing the surgery. Second group of patients, which we very commonly see now in the previous discussion in 2021, where already 15-20 years, the endoscopic surgery has established itself in deep and infiltrative endometriosis. We have started getting a lot of recurrent patients also, and we have started getting lesions which are beyond our routine area, like vascular endometriosis, GI endometriosis. So it has been proved that any lesion which falls in the category of deep infiltrative endometriosis, if it is present inside the body and if in vitro fertilization is being done, the results are compromised. So the RCTs have confirmed that there is statistically significant benefit of surgery before IVF. So in such scenario, you can take an alternative route. First, take out the embryos, freeze the embryos, then go ahead with the corrective surgery, so that even if there is some amount of ovarian damage or you lose some amount of ovarian tissue, you are not at losing end, and patient will be benefited both in terms of getting good embryos, and once patient is disease free, will have a better conception rate. So there is a definitive surgical role. So this was one of the largest study published in 2021 in Journal of Minimal Invasive Gynecology, where they have gone through systemic review of more than 150 articles and 98 studies. And they came across this very interesting data that pregnancy rate is 1.8 and pregnancy rate per cycle is 1.84 times higher, and the live birth rate is 2.2 times higher in patients operated for endometriosis than non-operated group. So this speaks in itself that in all selected patients, surgery is still a line of management. So there are pros and cons of both the things, because the surgeries are not simple surgeries. There are minor and major complications associated with these surgeries, especially when you are dealing with DIE. This includes severe hemorrhage, intraoperative and postoperative infections. There are repeated papers we see where after surgery or after pickup, patient has undergone patient had a bad episode of infection, ovarian abscess, and ultimately patient ended up losing the ovary. So you have to be very meticulous and careful about the infections. Lepro conversion, many cases, you have to convert it into open surgery, which technically is considered to be a complication of laparoscopy. Fistula formations have been noted, especially in incomplete surgeries followed by ovum pickup, or endometriosis in situ and ovum pickup is being done, and bladder and bowel dysfunction when extensive surgical clearance has been done, when sometimes in endometriosis compared to oncosurgery, now preservation is not possible because of extensive fibrosis. Identifying the inferior hypogastric plexus and sparing them is not possible, and in such cases bowel and bladder dysfunction is also there. And compared to that, not performing a surgery is also not risk-free. Untreated bowel DIE has higher complications during IVF as well as subsequent pregnancy. So there is always a dilemma. So lot of centers have started following this. They retrieve the eggs before any surgical intervention to get optimal out of the ovarian reserve, treat surgically the patient, let patient recover, let anatomy get restored, and then you can transfer to get the benefit of both the worlds. Second is ureteric endometriosis. This is on ever rise. One of the reason is previously only conservative surgeries were being offered. Now, for most of the centers who deal with endometriosis, to make complete disease free, they have started doing ureterolysis in almost all cases. Once you open the peritoneum covering the ureter, potentially whenever recurrence is there, you have opened a new space for disease to grow. And so we are getting more and more cases where endometriosis has entered into the retroperitoneal stage, which has led to ureteric involvement. Unfortunately, the symptoms are not typical of this. Patient will just have pelvic pain, dysmenorrhea, and dyspareunia, which is common to all endometriosis. But in such cases, the ureterohydronephrosis may be missed. If it is not addressed properly, may lead to significant compression, hydroureter, and hydronephrosis. This specifically happens in patients where there is subclinical or early disease. Patient undergoes ART, patient conceives for 9 months, the disease is untreated. And in lactation part, patient completely ignores the symptom. And when ultimately patient turns up, patient will have a less functioning or a non-functioning kidney with gross hydronephrosis. So whenever you look for endometriosis, any surgery is being done for endometriosis, be very vigilant to rule out hydronephrosis or any potential involvement of ureter in such cases. So if it is there, proper ureterolysis, if required, disease segment should be removed, and ureteral anastomosis. And if it is very close to the bladder, insertion or a large segment has been removed, ureteroneocystostomy should be performed. So this art now each and every gynecologist should learn, though for medical legal safety, you should have a urologist in team, but now for a person who deals with endometriosis should learn this art. In extension to this, 50% of the patient with hydronephrosis and ureteric involvement will not have any symptoms. Only 21% will have urinary tract symptoms like dysuria, polyuria, urgency, and recurrent UTI. So these are the ones which are very likely to miss. So any patient with recurrence or previous surgery you should be always cautious about this involvement. And as very rightly said, 9.9% ureteral obstructive symptoms are only there. So do not miss any ureteric involvement and address it surgically whenever you pick it up. So investigation and treatment should involve it. Then there is very typical and rare disease, that is bladder endometriosis. We are in an era where the C-section is, the incidence of C-section is increasing. Patient has undergone surgery once or twice. Patient already had endometriosis, and once these layers are opened, when you dissect the bladder twice, when there is inadvertent injury to the muscularis, you open a new space for endometriosis to grow, and patient will have typical symptoms of cyclical hematuria, and patient will have difficulty in conceiving next time. So these are the patients with secondary infertility symptomatic, and this falls technically into the category of DIE. And if it is found, proper laparoscopic visualization, mobilization of the bladder from the uterine surface, identifying the lesions. If it is away from ureter, just taking out the lesion and reconstructing the bladder is very important before the embryos are transferred back or you allow patient to conceive once again. So this one entity should also not be missed, and this is one clear-cut indication of surgery whenever you diagnose it. Third very common group of DIE falls is colorectal endometriosis. And we keep on seeing a lot of interest in young endoscopic surgeons about this. Rectum, sigmoid are the most frequently involved structures, and 90% would be with this two only. And the symptomatology includes pain, infertility, and most of these patients have long-term medical therapy or repeated operations. As very rightly said by a senior surgeon, that whenever the barrier of the peritoneum is broken once or twice, the endometriosis will get chance to go in the retroperitoneum or vital organs, muscularis and serosa, and this involvement is very common. So in such cases, the assessment includes total mapping of the disease, which may include physical examination, transvaginal sonography, a pelvic MRI, and certain cases colonoscopy is also important. Still, there is no 100% effectivity in prediction or confirmation. Many a times on a grossly less symptomatic patient, when you go ahead with laparoscopy, you find gross bowel involvement. So you have to be prepared for each and every case in such a situation. The surgery has emerged as a branch of choice in certain selected cases of rectovaginal endometriosis. But at the same time, when you do extensive dissection like this, when you go ahead and do remove a segment of bowel, especially in infertile patients, there are certain things which you should consider. And before considering this is the gross involvement of bowel in endometriosis. And when conservative versus radical surgery is compared in a patient with DIE involving the bowel, it has been proved by many studies that conservating, shaving or discoid excision of the surgery has fewer events of constipation and bowel movement, because the nerve sparing many a times is not possible in endometriosis. In endometriosis, majority of the times, because of the extensive fibrosis, the nerve is involved, and when you do pararectal or prevesical dissection in all such areas, you are likely to damage these nerves, and patient will have bowel and bladder dysfunction following the surgery. There are reported cases of intermittent self-catheterization for first few months to years after this extensive surgeries, especially when nerve sparing is not kept in mind. So these are some gross complications of extensive surgery. So you have to be very careful. You have to counsel the patient. You have to properly select the patient, because we are talking about patients with infertility and endometriosis. So the treatment should not never put patient in a situation which is worse than the disease itself. So you have to be very careful. Urinary dysfunctions have been noted after surgery with DE. Retention rate is up to 30% after surgery, and a persistent voiding dysfunction has been noted in as high as 17% in some studies. And this is not a very old but a very new report, where all these surgeries were done under either HD, 3D or 4K camera system with newer technology. So in spite of that, these complications are there. So try and avoid surgery. If it is mandatory, try to be conservative in patients who are infertile. So if you are able to deal with majority of the disease by rectal shaving, try and avoid discoid. If you are able to do it with discoid, try and avoid dissection anastomosis. If you are on conservative side, you will give a better quality of life, better recovery, and better chances of getting pregnant without any symptoms. So to conclude this, there is one more thing. Sometimes we get disease in very lower rectum, and there is something known as low anterior dissection syndrome. And here the quality of life is grossly affected. Patients may have urgency, fecal incontinence, a very high frequency of passage of stool, and that sometimes liquid stools, and grossly altered bowel habits. So in all such cases where bowel involvement is there, counseling of the patient is very, very, very essential. If patient is willing to go ahead with the medical treatment and postpone this for a while, should always be considered. So before I conclude my talk, surgery has definite role. Complete clearance definitely improves the fertility, but you also have to balance between the poor ovarian reserve, recurrence disease, where sometimes you can avoid the surgery or you can restrict your extent of surgery for the benefit of the patient. So procedures that can have serious short or long-term implications on the quality of life, like Large syndrome, bowel or bladder dysfunction. In such cases, proper counseling, proper planning is very important. And I have not touched, because of the paucity of the time, the adenomyoma. Now, a lot of studies are coming up that surgery has a very limited role when you're dealing with adenomyoma in infertile patient. Medical management should be tried, and ART should be first line of therapy. And one very interesting study before I conclude, that 25% of the general OB/GYN specialists felt that they do not properly understand this disease. So if surgery is required, it is to be done by someone who deals with this day in and day out. He has seen the complications. He knows where to limit an individual patient. So it should be done in a by a high volume surgeon, where he has access to all the specialties involved. Thank you very much.
Yeah, wonderful talk, Dr. Sujal. How far to go, and definitely the patient selection is very, very important, and also the surgeon who does it is another important issue, which should be, I mean, which should always be, which is also is a priority actually. So over to Dr. Nisha for your comments.
Yeah. Thank you, Dr. Jyoti, for allowing me to chair a session of a very diligent endometriosis surgeon. It's a real pleasure to chair his section. Dr. Sujal Munshi is very well eminent surgeon. Very diligently touched the topic, very, very rational, very patients to carefully select, as he rightly said, that we have to look at the symptoms, the size of endometrioma, her AMH levels, and how much we are looking at malignancy. What are the associated problems like adenomyosis? And then, proper mapping of the disease when we want to. And and efforts the last done by the most expert and everybody surgery. And once
Your voice is breaking.
I think there is a little
the preservation. Hello, am I audible?
Yes, yes.
In between sometimes.
Sometimes. Madam, you can close the video for
Okay.
better bandwidth. Yes.
Yeah. So very well spoken, and thank you for being with us and all of us on when to do surgery, how much to do. Thank you very much.
Thank you.
Thank you. Dr. Sujal, what is your take on sandwich therapy or sandwich treatment that they do for very big endometriomas? Have you tried that, and what do you say? Should it be done? What exactly is it?
So when I started my career in 2006, 2008 to 14 was the time when there was a consensus that remove each and every implant, remove whatever cysts available. But gradually, when we started doing this, we realized that there is a potential harm to the ovary. And that is why for a short time, the sandwich therapy came, where you give medical therapy, you do the surgery, you again give suppression, and then whatever definitive treatment is to be done has to be carried out. The only disadvantage I feel about the sandwich therapy is after medical therapy, when patient is posted for surgery, then the surgery is not as simple as in the patients where it is a virgin abdomen. So any medical therapy, be it Dynogest, be it GnRH, will compromise blood supply and will cause slight alteration of the texture of the tissue. And in such cases, when you operate, chances of ovarian damage is little more. You have any meeting ma chupa karu. So you have more ovarian damage, you will have less chances of success, and that is why it did not become very popular for very long time. Now the consensus is try and go ahead with fertility treatment if it is feasible. Only in selected cases where very large disease is there, you have recurrent failures, or patient is grossly symptomatic, then only surgery is to be done. In those cases also, if there is a possibility of retrieving the egg, creating the embryo before the surgery, explore it, then do the corrective surgery, and then go ahead with the transfer.
Congratulations,
Right.
Dr. Sujal. I'm so proud you're from our Ahmedabad. I wanted to ask you, though we know that we're not supposed to give any medical management to the surgery first, but it is somehow not feasible in all cases. Sometimes we do need to give some medical management to these patients when they're too young, adolescents, very huge endometriomas, and they want a little bit conservative management. So, in your experience, which molecule do you think would be the best one? I know letrozole. I know that Dynogest people, all including Sanjay Patel, everybody grumbles. That's Dynogest should not be given. That I know. What about GnRH agonist? Do they really hamper the similar way as Dynogest? What is your take on that?
So,
You
madam,
told that all the medical management, but according to me,
yes. If I want to categorically tell, out of this, the OC pills or normal progestins are considered to be the best. OC pills has an advantage that patient will keep on getting the cyclical peeling. So in such cases, the texture and the tissue is preserved in very well state. For Dynogest also, when it is given for short term, it does not affect the tissue texture. What we recommend is before surgery, if once or twice if patient has normal menstruation, the tissue comes back to normal. But if it is taken for very long time, 3 years, 4 years, and patient did not have any exposure to estrogen in between, then the consistency and type of the tissue changes. It becomes very elastic, and then the modification of the surgery is required. But you can do it. So in all indicated patients, Dynogest is a good molecule. It takes care of the symptoms very well. 6 out of 10 you can avoid a surgery which is major thing. So in 6 cases, if you have to take a little extra effort, you can take that efforts. Considering the elagolics, it is available for very short time, so it is very difficult to say at this point of time what effect it will have on the tissues on a longer run. So we will have to wait for 2-3 years when we start getting the patients who are already on elagolics, and then we operate on it. And fortunately, if things don't happen in that way, then it is good for all of us. For GnRH, it only reduces the blood supply. So the tissue loses its elasticity. They become more dry. Surgery is little difficult, but in such cases also, it can be used in indicated patients. So
what about medroxyprogesterone?
Medroxyprogesterone is similar in action as Dynogest, but it is a little less efficacious in terms of this. It also has little androgenic component to it. So the changes in tissue is little less prominent compared to Dynogest.
Thank you so much.
Dr. Sujal, I have a question whether there is any role of laser ablation of the endometrioma lining, or the recent thing which is coming up is the alcohol instillation within the cavity of the endometrioma in patients of infertility where ovarian reserves are already bad.
So basically, if you look at laser, bipolar, or a monopolar energy, ultimately they are all energy sources. They will do little or more amount of destruction of the ovarian tissue. The advantage of alcohol is it is only surface which is exposed to it, and it is kind of sclerotherapy. So with alcohol, the advantage is there is hardly any ovarian reserve damage. The recurrence may be there. There are a few cases where recurrence have happened, but it is a very less invasive surgery by sono-guided or by laparoscopy. You can do this. In European countries, they have been doing it for now 4-5 years, and they have very good results with it. For in India, we don't have medically permitted alcohol available for this use, so it has to be done under research settings only, and that is why our own experience is very limited with it. But
Right.
whether it is laser or bipolar, destruction is going to be there. With laser, it is going to be under control. With bipolar, it is not under control. So spending too much money on laser does not have that added benefit that it should be a part of your instrument list. If you have it, it is a legacy. Yes.
Right. Thank you.
Yes.
Yeah, thank you so much. Thank you, Dr. Nisha, for touching upon the sclerotherapy part as well, because some people say that recurrent endometriosis, if nothing can be done, definitely this is one thing that you have in your armamentarium that you can at least try for those particular cases. And I think Dr. NM sir has been doing such sort of sclerosing. He talks a lot about that. So maybe once he is there, we can ask for his experiences as well. But definitely wonderful talk, Dr. Sujal, and the videos are wonderful. And thank you for coming on this platform. And hope to see you soon again for some of our another program. So moving on, we have now our panel discussion for another 30-40 minutes, for which we have our special guests or experts, let's say, Dr. Kanti Bansal and Dr. Smita Arora. So Dr. Kanti Bansal, all the way from Ahmedabad, the beautiful lady, director of Safal Fertility Foundation, and she's done a lot of work on endometriosis. She has 12 books published on PCOS, endometriosis, infertility, ART, and these are being used by medical students as references. She also is a director at Safal Fertility Ahmedabad, a chief IVF expert, Sneh IVF Center, Bhopal, Ahmedabad, and a pioneer in the field of ART in India and Gujarat. She produced the first IVF baby of Gujarat and Ahmedabad. She also is a pioneer in artificial intelligence, virtual reality, and haptics in ART. She has been awarded the RCOG Distinguished Service Medal in 2020 and invited by Aspire as working committee member. So welcome, Dr. Kanti, and I'm sure your insights are going to be very, very useful to us. Dr. Sunita,
Thank you,
I
Dr.
think has
Jyoti. Being in, said that I am beautiful from such a beautiful girl like you. Thank you so much.
Thank you. So we have our second expert, Dr. Sunita Arora, I think is yet to join. She is director, she is the chairperson of the Delhi ISAR, and she is currently director at Dr. Sunita Arora Fertility Gynec Clinic at Safdarjung Enclave, and also she is at La Femme IVF Center. She has more than 22 years of experience in this field. So she'll be joining us maybe in between soon. And we have our panelists today from different parts of Haryana. We have Dr. Jyoti Gupta, and from Gurugram, Dr. Rakhi Goyal from Chandigarh, Dr. Niharika from Faridabad, and Dr. Rubina again from, I think, Gurugram. Yes. So welcome our panelists, and our moderator is I've already introduced Dr. Manju Dagar, our clinical secretary. And we would together we would be going through this panel. I think it would be. I'll just share my screen so that we can start with the with this. So I think it is visible now. I've already told about our experts and our panelists and our moderators for today evening, and we are going to be discussing on endometriosis in different, I think, walks of life. As Dr. NM sir has already discussed about the endometriosis, that it takes a long time by the time we are able to diagnose it. Nearly 6 to 7 years down the line it takes by the time we are able to convincingly say that, okay, this is what we are dealing with. And it can include young girls, these days adolescents do come with endometriosis, and we have these patients presenting with one or more of the 7Ds. So, and the confirmation is by laparoscopy, mainly, I think that is the confirmatory, though even ultrasound, CT, MRI, these are the diagnostic modalities, but sometimes nothing can tell us that this is endometriosis. Even laparoscopy, sometimes on histopath also, it may not come out to be endometriosis. So the 7Ds are dysmenorrhea, dyspareunia, dysuria, dyscasia, dysfunctional uterine bleeding, difficulty in conception, and anybody presenting with the diffuse abdominal pain. So if you have any of these things, think endometriosis. So we have so many guidelines to manage patients, but there is no last word. And so we come on to Dr. Kanti to find out this. So does a early diagnosis versus a late diagnosis lead to a better quality of life?
Jyoti, I think it's a very interesting question that you've taken up as one of the first questions for this panel. I definitely feel that early diagnosis is very, very important. And it will also, because the disease is, cut short there itself. And it goes a long way in her life, both in during her teenage as well as the reproductive age. So I definitely diagnosis of endometriosis is very, very important in the early phase.
Right. So we should, the guidelines recommend that in symptomatic women, attempts should be made to relieve symptoms either by empirical treatment or by diagnosing the treatment. And so we come on to this first case. Dr. Manju, we can start with this case.
So very good evening to everyone. So let's go ahead to the case. A 16-year-old girl attained a menarche at the age of 13 years. And she complained of severe dysmenorrhea with frequent absenteeism from the school and interfering with the daily activities since last 6 to 8 months. Her menstrual history is 5 to 6 days, 28 to 30 days with average flow and severe dysmenorrhea. Partial relief with the meftalspas. Family history, her mother is attained menarche at 12 years and with mild dysmenorrhea she is having. And her younger sister is 10-year-old. So, so how you will proceed with the management part? In this case, we advise an ultrasound, we do some blood testing and then treatment part. So we did an ultrasound and we found the uterus is normal size, her endometrium is 6.8 mm, myometrium is homogeneous, and the left ovary have 4.5 centimeter cystic lesion with internal echoes and right ovary 2.5 centimeter cystic lesion with the internal echoes, means bilateral endometrioma she is having. So which diagnostic procedure should be applied in adolescent with possible endometriosis? And what is the best
We can start with Dr. Jyoti. Dr. Jyoti Gupta and then Dr. Rakhi can take the second question. So what diagnostic procedures should be applied in patients where we have possible endometriosis? We are not sure. And then we come on to the second part of the treatment part.
Since she's a adolescent and young female, so ultrasonography is one diagnostic tool that can give us an idea that she's having endometriosis, because her clinical history is also giving that she's having severe pain and that dysmenorrhea, severe dysmenorrhea. So ultrasonography can be done, and certain blood tests like CRP and can be done. But if since it's MRI and CT can be done if it is not visible on ultrasonography. But since the endometrioma that you have shown that ultrasound is less than 5 centimeters, so medical treatment can be done in such cases before proceeding for surgery.
What is your preferred modality to do in these cases? Like she is presenting with the ultrasound we did, and where is the role of MRI and where is the role of what you decide, TS or TVS or what ultrasound?
Ultrasound, since she is unmarried adolescent girl, transabdominal ultrasound will be done. Most of these endometrioma, we are able to distinguish them on ultrasonography only. The heterogeneous echoes are there, and so it can be diagnosed on ultrasonography. If there is doubt, we are seeing that it is extended and the anatomy is distorted, MRI can be taken with contrast.
Can I just come in this, Jyoti? Yeah, so I think before going to any diagnostic procedures, the history taking is very, very important as far as these young girls are there, because many a times they complain of dysmenorrhea. That is during the menstrual phase, they have pain. But whether they are having a spasmodic dysmenorrhea, whether they're having congestive dysmenorrhea is very important. And that has to be taken in depth. And sometimes, the intensity of pain, many girls, they bunk their classes, they go out for, they say my abdomen is paining and then they bunk classes. We have to go into the depth of the history, asking the mothers whether she's clutching her abdomen and sleeping and, crying, or is she just not going to the classes and enjoying her life. So we have to go in the depth of the history taking, especially the congestive dysmenorrhea is very, very important. So congestive is what happens about few days before it starts, few days before the menstrual cycle begins. And spasmodic is normal. Spasmodic is where one gets ovulation, and that's where they have the dysmenorrhea. Many just now one patient of mine had come and now she's pregnant, thank God. And she had gone to several, I'm sorry to say I'm not condemning any doctors, but then that is the true story. She had gone to many doctors in Rajasthan and they had not diagnosed endometriosis. And by the time they said, they all told her it's normal. This dysmenorrhea is normal. So we have to correct ourselves there. And once we know that it is endometriosis because of congestive dysmenorrhea, and then move to all the, all these guidelines are there, they will help you more. Yeah.
Absolutely.
So once the patient comes into the OPD, just by her look also we can, make out when if she's come during her just before her
Period
menstruation.
time.
Yes.
Absolutely, very right. You pointed out, Dr. Kanti, that we have to be, I think a careful history can give us a lot of insights into what we are about to deal with, what that girl is talking about, or whether she's feigning. Because right in the first slide that Dr. NM sir had put, he has shown that these patients go from doctor to doctor, and then everybody says it is quite normal, as you said, that all these patients were taking. It took a lot of time by the time a diagnosis was made, and definitely a careful history into a positive family history, also finding out obstructive genital malformations, early menarche or short cycle. These are a very strong recommendation that the guidelines put into the history taking. Also about the absenteeism from school, or whether she has been using oral contraceptives for the treatment of dysmenorrhea, like NSAIDs did not help her, and later she had to be put on these OC pills. So this again is an indirect indicator that maybe then we should start suspecting that there is a possible endometriosis here. So a careful history of the type of pain, whether it is a cyclic pain or it is a acyclic pain, and if it is combined with nausea, dysmenorrhea, other symptoms of dyschezia, dysuria, etc. So all these things should make us like, these are the red flags that we should be we should think of. So the treatment part now. So we can go on to the next question that we were thinking. I think Rubina can take this. The treatment for adolescents with suspected endometriosis. What do you? Sorry.
Now, the treatment for endometriosis in adolescent, firstly, should depend on how much pain she's having, what is her complaint, and how much absenteeism she is. She's not able, how much it is affecting her quality of life. If it is affecting her quality of life, that in a way that she's not able to attend school, college, so definitely she needs conservative along with a long-term therapy. But if she is able to manage, she's only having mild problems, then initially we should only start with NSAID. Eventually, we should put her on long-term medications like, progesterone only drugs, which can reverse the problem, so that the problem will not eventually become like, the cyst will not increase to a level where it hampers her ovary before her fertility needs to be achieved. So I feel conservative management at this point, where she's already being diagnosed with 4 centimeter endometrioma, she only needs conservative management, but not surgical management.
Yeah, one more point I wanted to add. I just suddenly remembered when this was being told, that after diagnosing, this is as far as diagnosis is concerned, I think one injection of GnRH agonist to give the
Can be
girl,
given.
and then if the symptoms disappear, it's 100% that this girl has endometriosis. So this is also one point that I wanted to say. Yes.
Right. So as Dr. Rubina has rightly pointed out, the best treatment actually would be a pain relieving for her. And if needed, then she can be put on hormonal contraceptives or progestogens. Now, this is something very unique that the guidelines do suggest that a LNG IUS is a first-line hormonal therapy for her. Now, how many of us have used it? And because these are, I think, Western guidelines, which I don't think in our Indian scenario we do follow. And anybody has any experience using a LNG IUS on adolescent? Because this is a strong recommendation by the guidelines by using it as a first line hormones.
I
Any
think we
comments
did not
from any?
go on this, the Western world recommendations, because in our country, the way we have been brought up, the parents will not allow us, and the girl also may be hesitant, and we ourselves will not be willing to put a LNG IUS. We have
Yes.
different modalities like, the oral contraceptive pills, the progesterones. So I think we can use them. And these days we are also using, I thought I'll come to it a little later. There are some other nutraceutical products, I think many of you will be knowing, that we can use, something which is not causing harm to her. That should be our this thing. Not that LNG IUS causes harm. It may benefit her, but then that we can use at a later stage when she gets married and, is sexually active and all that.
Yeah. So there is for the GnRH agonist, actually, there's a weak recommendation, and they suggest that only when you have laparoscopically confirmed endometriosis, and there you have already tried hormones or you have tried progestogens and they have failed, then one can go in for agonist for up to a year. And after sort of explaining to the patient about the probable side effects, the long-term health risks, and then also again combining it especially with the add-back therapy. So this is very, very important, that whenever we are giving them agonist for long, I mean, just 1 or 2 shots are okay, there is no need. But otherwise, if it's for a long-term use, then definitely a add-back therapy is something which we need to suggest to them. So I think the first line.
Dr. Jyoti, 1 minute,
Yes,
the
yeah,
previous
Dr.
slide.
Yes.
So they say that after laparoscopic confirmation, but according to Professor Shapron, who is a world famous endometriosis surgeon, he was there in one of my conferences that I had organized initially, and he has a very good paper and has proved that in a woman's lifetime, there should be only one laparoscopic surgery for cases of endometriosis. Means so judicial we have to be. We cannot sit and operate her initially, or we cannot even operate her once the disease progresses too much. So we have to, that judgment is very important. So anyways, for young girls, I don't think we should be doing
surgery at all.
laparoscopic
And
surgery.
there are special indications in adolescent endometriosis. One is patient is not responding to your medical management, and when endometrioma is more than 5 centimeters, not responding to the treatment. Then only we can go ahead with the laparoscopy with the thorough counseling of the parents and to the girl, because it's very difficult to counsel the parents and to the girl for the laparoscopic surgery, like an organ like ovary. So it's difficult, but sometimes these are the indication that we can go ahead. But in the guidelines, in the present scenario, there is no role of diagnostic laparoscopy for endometriosis. If we are suspecting, we can't do it.
Right.
And we have to offer fertility preservation also, if we are going ahead with the operative laparoscopy.
Yes.
So now this Dynogest is something, a magical drug that we've got. So how many, what is experience, Dr. Raki, that you have used Dynogest in adolescents? For how long have you used? What are the guidelines for how much time it can be used? And what are the special precautions that we should take while using it?
Personally, I have not used in the adolescent group, because I generally deal with those who are planning a pregnancy, or post-operatively they are planning to delay the fertility for a short while. But still, Dynogest is a very good drug, and but it has a short-term effect on the BMD, which is reversible after stopping it. So we can offer it to our patients, but it can also cause this hypoestrogenic side effects in some of the patients. And some patients are not, it can lead to amenorrhea also. So adolescents and the parents need very well counseling also. Indian scenario, na, parents are very worried कि regular cycles नहीं आ रहे, periods बंद हो गए. This can lead to, or it can lead to this intermittent spotting and irregular bleeding also in the initial months. So a good counseling is needed, but it's a good alternative if the first line drugs, the OCPs and the NSAIDs are not working.
Right. So we have, okay, now also this, suppose that was about this first case. Now in this second case, it is the same scenario. It is a young girl, but the size of this adnexal mass is quite big.
12 centimeter.
It is 12 centimeter. So now what is everybody's sort of take and management in that particular case? The CA125 levels is also a little on the higher side. It is
हमारे घर में
46.
हमारे में खाना पीना बैंड है
What
सारा
should be done? Dr. Niharika, now if you are there, you can take up.
नहीं लेकिन मेरे को तो वैसे थोड़ी देर बाद चाहिए था लेकिन मैं नहीं पी रही हूँ इसको मैंने
Okay.
Ma'am, first of all, in this case, as the adnexal mass is big, it's almost 12 centimeters. So first, after doing the ultrasound, we need to do more invasive diagnostic things, like we should go for MRI. MRI would detect whether it is actually a endometrioma. It is the what kind of cyst is this? It is arising from the ovary. It can be some obstructive pelvic lesion also. It can be rudimentary horn also. So we should have a proper diagnostic imaging technique after doing basic ultrasound in adolescent. Obviously, we will do the transabdominal, then tumor markers plus MRI, CT plus minus, but MRI should be there. Then depending on all the things, taking into account the markers value as well as the MRI findings, she should be counseled for having the surgical procedure first rather than the conservative. This is my opinion because the cyst is very big. So GnRH analogs, if it all will give, it will take a long time to let it be suppressed to 4-5 centimeters. And by the time it will be 4-5 centimeters, the patient will be in lot of pain due to this. And obviously it can rupture also. So many times it can, if it is arising from the ovary, the ovary can go into torsion also. It's a little risky to let it be inside the abdomen, rather to take it as more a radical approach. So proper then parents and obviously the girl should be counseled, and taking all of the account, the surgery should be done, and definitive diagnosis will be done after laparotomy or the laparoscopy as per the expertise of the surgeon. That's my take.
Very right. So, Dr. Jyoti, we are now this adolescent girl taking her up for surgery. As Dr. Manju said, parents do not agree, and we have to think maybe 10 times before putting her under knife. So, what all do you talk to her? What all do you plan for her? And what type of surgical precautions that you would take for her?
Actually, she's unmarried and adolescent girl, so keeping the surgery minimal, that before without any fertility preservation surgery should be done. And before proceeding, we have to consult the patient that her AMH must be may be affected, and AMH should be done. They should be, but it's only in one ovary, so I'm hoping that the other ovaries is also fine. So that she has a good chances of pregnancy in natural pregnancy involved, and so properly, and actually cyst should be removed, not only the drainage and is of the cyst should be done, and fertility preservation is important before proceeding the fertility, that we have, yeah.
So there should be a very good counseling about the surgery, cystectomy, because there is a decrease in ovarian reserve, whatever method you choose. So you can offer simultaneously that after post-operatively, post-surgery, immediately after post-surgery, you can do egg freezing. And IVF in these cases, this point you have to counsel beforehand, before the surgery. Because sometimes then patient relieve the symptom, then patient lost, and later on they lost their future fertility and then they regret it. So at least we should counsel these patients beforehand, before we plan the surgery. Look, these are the side effects, these are the advantages, and these are the steps that you can preserve your fertility for the future.
And one thing more, it should be done by a surgeon that is trained for
Yes, yes.
not for.
Actually, I suggest that, we all are good surgeons, but then there are experts in this field. So we should send them. And one more thing I wanted to say, that though it is such a big endometrioma, she's very small. She's just 20 years. So, and, in some of my patients I have seen, by giving Dynogest, these endometriomas, they shrink. Some of them really shrink. So we should give her a chance and see if this initial shrinkage and whether we can continue with the medical management. Be always conservative in young girls. That is my take on this. Though because it's 12 centimeters, then again we think, oh, what do we do? But we should always try with some medications, try see whether it shrinks. If it doesn't, then with proper counseling to the parents, to the girl, and everything. Before the operation, you have to do her AMH and everything, and then again after how many months you will do the AMH again, Dr. Manju?
Yes, ma'am. Sorry.
After the surgery, after how many months will you do the post-op AMH?
After 3 months.
Ma'am, at least we should take 3 to 6 months after the surgery. We should do the AMH. Immediately after surgery, give the false report.
Yeah.
So we should take a good gap to repeat the AMH.
6 months should
3
be
months to
minimum.
3 to 6
Yes,
months.
6 months. And also you should give her some post-operative medications to curb the development of immediately one more
To
endometrioma.
prevent recurrence and to take care of her pain. We can give the
Yes.
post-operative management in these cases. Thank you.
So actually, these are the cases where post-op treat to
Madam, it's
prevent
very
recurrence.
difficult
It
to
is very, very
counsel.
important
Yeah,
to give
it's
them.
an adolescent patient, even with the 12 centimeter cyst, it's very difficult to counsel the patient and the young girl for the surgery. It's very difficult. They will take a lot of consultation, lot of opinion. After that, they agree, yes, there is a risk. And
But
now we
actually, if they have pain,
Yes,
if they have
ma'am. That's
pain,
what
they
I'm
do get.
saying. That 12 centimeters, the girl would be sitting as such. She will be having some or the other, maybe on the severe side pain. So half of
But
job
we
is
also
done.
should
Yeah.
focus a lot on fertility preservation after this, because a lot of time they're not very serious, and the consequences they have to face later in life is quite high. So we must be very focused in our counseling regarding fertility
And
and
one thing,
upcoming fertility problems post surgery.
in the meantime, when they are planning and they're consulting other doctors, we can give them a trial of Dynogest in the waiting period.
we can take one opinion from Dr. Nisha at 12 centimeter endometrioma in adolescent mother.
Yeah,
And the surgical tips that we need to follow if at all we are going ahead with the surgery.
Yeah, thank you for asking me to comment on this. First of all, I strongly feel that 12 centimeter cyst, if we put her on conservative management, it is just going to make the surgery more difficult. As Dr. Sujal also said, the planes are going to be more fibrosed and the dissection would be difficult. And in the process, possibly we might land up, losing more of a variant tissue if we do not get the planes. So once we know that a 12 centimeter cyst has to be removed, postponing it was further going to the endometrioma itself by the compression effect on the normal ovarian tissue is further going to damage her ovary, the increasing size of the endometrioma. It's a big endometrioma. So she is not going to get better, I think, by waiting. In this case, we should operate. But two things I definitely agree with all of you, that fertility preservation is very important part of the treatment. So she is not that young also. She's 20 years and maybe, she has to get married in the next decade. So fertility preservation must be counseled to the girl and to the parents as well. And also, it is very important that once we have done the surgery, the follow-up of these patients is very important. We have to explain to them that in no case she should have recurrence of the cyst till the time she gets married and she, completes her family. That's so very important to keep them under follow-up and, suppress any small recurrences which are coming up by medical management. That is again very, very important. And of course, Dr. Sujal has already said that while we are doing surgery, of course, this is the standard that we have to do cystectomy, not drainage or laser ablation or other thing. That is now amply clear that cystectomy is the best treatment to avoid recurrences. And while doing cystectomy, we should be using energy to the least, should be using other hemostatic measures like injecting vasopressin and doing hydrodissection and carefully selecting the plane. Sometimes, when you are starting at the periphery, you may not get a good plane. In such cases, we just give a superficial nick at this, we invert the ovary inside out and we give a nick at the center of the cyst wall and start enucleating. You get a better plane in the center sometimes, and then in two halves you can remove the cyst wall very carefully. And if you think you are taking too thick a capsule, you can shift your place of enucleation to some other area where and start enucleating, with a thinner cyst wall. So one has to be very carefully watching that, you don't remove unnecessary healthy ovarian tissue. It should be very, very nicely and carefully enucleated. And also, when you are sort of having any bleeding, injecting vasopressin again into the uterus, I have found very helpful that, you inject more vasopressin, towards the end of surgery, leave the patient for 5-10 minutes and again do the washing. The most of the time the bleeding would have stopped. So must avoid cautery, at all stages. So that is my take, Jyoti.
Thank you so much, Dr. Nisha, for actually wonderfully explaining. And this new technique of everting and bisecting and then peeling off is something I recently saw in I think by some lab surgeon, must be Dr. Sanket. I saw his video, the thing that you are explaining, and it was wonderfully the way it peeled off, and it was a huge cyst, and the whole ovary could be everted, and the cyst wall could then be removed very nicely. So it is a very new
reconstruction also leads to hemostasis. So if there is endometrioma, do a good ovarian reconstruction, and that will also stop the bleeding.
And even it help reconstruction of the ovary will help us in a future pregnancy
and prevent adhesions of bowel and all, and egg retrieval is easy.
If it's a large endometrioma like this, I think the reconstruction is going to reduce the raw area which is available to the intestine to come and get stuck over there. And while reconstructing, we should not be doing layering and all that. The idea is just to put, 1 or 2 mattress sutures and bring the edges together so that you don't strangulate the ovary by doing a lot of suturing. So that is very important.
Right. So coming on to the third case, Dr. Manju, we come on to infertility.
So the next case, the patient is 28-year-old, married since last 4 years, trying to conceive since 1 year. Menstruation is perfectly okay, normal, average flow. And she is suffering from dysuria, dyschezia. And she took 2 to 3 cycles of ovulation induction with clomiphene. Next, Dr. Jyoti. So her husband's semen analysis is normal. Hormonal test LH, FSH is perfectly okay. Thyroid is normal. AMH is 2. But her right ovary has a unilocular endometrioma, 4 centimeter. So how you manage this case? How you go ahead? Whether you consider direct IVF or laparoscopy followed by IVF. What is your take on this? Who will take this question?
Ma'am, as the cyst is big, it's almost 4 centimeter, plus she has a symptom of dysuria and dyschezia, which gives a hint of the deep infiltrating endometriosis. So she should be taken up for diagnostic laparoscopy that well as and hysteroscopy that will diagnose and staging will help in staging the disease as well as will do the therapeutic fulguration also in this case. And this will help in deciding further plan of the patient, whether what is the status of the tubes, whether they are open, they are adherent to the nearby structures, what about the uterus position, whether it is fixed retro in the retropersion. First of all, she should be counseled for seeing her ovarian status is good. Her AMH is 2.3. So reserve is already not bad. So she should be counseled for having the first laparoscopy and hysteroscopy, and then depending on the disease and status of the stage of the disease, whether she is having mild to moderate disease, minimal to mild, but as her symptoms is revealing, she is having bladder symptoms along with the bowel symptoms that she is having the moderate to severe one. But knowing the proper things down in what is inside, it is better to have this.
These are the findings you are telling me, the laparoscopy. So we are asking where to go ahead directly IVF and where to go ahead laparoscopy first and then IVF. But what are the factors you decide? Let me go ahead with the IVF directly. Dr. Rakhi.
I think I won't offer her an IVF straight away. IVF before a surgery before an IVF is generally only done when we see that the follicles are not accessible. The endometrioma will come in the way of her opio needle. So if most of the follicles are accessible, then we don't prefer doing a surgery because of the harmful effect on the ovarian reserve. Then we prefer to do an OPU first, freeze the embryos, and then later on, depending on the symptoms, if the patient requires a surgery. In this case, I would basically properly offer the patient two options. We can do a SSG or an HSG for the tubal testing. We can do 2-3 cycles of IUI. If does not work, we can go for IVF. For the endometrioma, only for the endometrioma, I don't prefer doing a surgery. Symptoms of this dysuria and dyschezia. We have to see how much is the intensity of the symptoms. What is our first preference, the pain or the infertility? Because many of the patients, if we are suspecting a DIE, they don't consent that if she requires a major surgery, she might have to do this, some intestinal complication, or a colostomy may be needed. So they don't give consent for that also, for too much of extensive surgery. So as we have repeatedly discussed that we don't want to do a surgery again and again. It should be a complete good surgery. So we will come for her. I think she's 28 years old, no?
Yeah, 28 years old.
28 years, 28 years, AMH of 2 is, I would say, borderline. She does not fall into a low reserve patient, but she's young and she's only AMH of 2. So see the AFC also, how does it correlate with the AMH? And do a counseling, well counseling, and then leave it to the patient how do they decide whether they want to go for a surgery first and then an IUI, and does not work, go for IVF accordingly, or do an IUI first and maybe skip the surgery if the symptoms are not too much.
So, Dr.
So
Jyoti,
prefer candidate
would you
for
like to
IVF is-
refer? Dr. Jyoti, would you like to do a laparoscopy?
I am not in favor of surgery for infertility patient unless I'm not able to see the follicles, normal tissue, ovarian tissue are not accessible, or the patient is having severe pain that she's not able to sit in my OPD, or she's lying down in the couch. So I have seen those patients only, then I would prefer to take them for surgery first. But in this case, I agree with Dr. Raki that I will check their tubes. If they are patent, I will take them for IUI, 1 or 2 cycles. If it is not, then IVF, then down regulation, and then transfer. That will be my.
So there are few factors, Dr. Jyoti, that to we decide whether to go ahead for IVF or for laparoscopy. Like if patient is older, her AMH is low, if size of endometrioma is big and interfere with our ovum pickup, and we have to see the patient is symptomatic, suffering from pain, and if there is a semen sample is not good, tubes are blocked. If there is already one previous surgery, we should not go ahead with the further surgery. And these all are basically the factors that we decide whether to go ahead for laparoscopy and for IVF Pro. And then we counsel the patient, and then they take the patient consent and her choice into the picture, and then we can plan the mode of treatment.
But
You can complete,
Dr. Manju. Her AMH is borderline. She's 28 years. So I'm deciding more on that.
That is the only gray area, na? She's young patient. AMH is good. So both options are available with you. So how you go ahead in this case? Some are saying laparoscopy, some are saying IVF. So what is the consensus?
Yeah, so according to me, in cases of endometriosis and infertility, the age of the patient is very important. How many years of married life they had, that is also important. they're having sex together. That is important. And also, what is the stage, from how long has she been having this pain, endometriosis, and what is the stage, etc. All these are important. But in this particular case, she's just 28 years and she's married for 4 years. So we'll have to decide whether we want.
But she's trying for only 1 year.
So that is important. I was just coming to that. She's only trying from 1 year. So after 1 year, we label them as infertile couple. But so we can go ahead with a conservative method. As somebody, one of the panelists very rightly said, if it is stage 1 and 2, then we have we have to go for IUI. What I would do, really speaking, I'm more conservative. Maybe just one cycle I would have tried with letrozole. She's just 28 years.
And she took 3 cycles of ovulation induction already.
She had? Okay.
She had 3 cycles of ovulation induction already.
So then the next best thing would be IUI. And in endometriosis, we have to remember whenever we do IUI, it has to be done with COH, that's controlled ovarian hyperstimulation. Then the results will be at par with what we do in unexplained infertility. That means we'll get a good number of pregnancies. So for this patient, instead of putting the patient on for surgery, not all patients are for surgery. We should go step by step. And believe me, you should use injectables. Because already she had the induction of ovulation by medications. You don't know how good results we get with, I'm not marketing, but really with gonadotropin, very good results. And could decide the dose and all that. Yeah, that is my take.
And that will also depend upon whom she visit the first. If she visit us, then we will go for IUI.
No, I do not agree. I do not agree. I'm a laparoscopist.
So we have both the surgeons and the infertility specialist here, and it has to be a different options apply, shared decision making, no role of hormonal treatment, but definitely between surgery and medically assisted reproduction, we have to decide. And if we have done a laparoscopy, EFI could be used to understand whether we can go in for, we can give her a conservative approach, or we go ahead with the IVF or the ART treatment early. So, yeah, Dr. Nisha wanted to say something.
Yeah, I just wanted to intervene because it is not that, she comes to laparoscopist. So that is wrong to say. I had exactly the similar patient today. She came for second opinion. She was advised surgery for a 4.5 centimeter endometrioma and she is infertile. And she's 38 years with an AMH of 0.8. And she was advised surgery, that you should first undergo surgery and then go for IVF. I told her your AMH is already very low and your age is already 38. So I will not touch your endometrioma till the time your IVF specialist is going to tell me that he or she cannot take out the eggs, in the presence of this endometrioma. So please go to IVF specialist. I gave the number. I rang up the IVF specialist that so-and-so patient is coming to you. Kindly consider her. And if she really needs a surgery, then you let me know. Then I'll go ahead and do the surgery. But then before that, I mean, it is, we all are quite sensitive to the needs of the patient. And now we have so many nice guidelines coming up. No, before there was a lot of confusion, but with the ASHRAE guidelines and everything, I think the things are very, very clear when to operate and how much to operate. So that is the basic crux of the whole exercise. Thank
So,
you.
Dr. Jyoti, it is not true that if she has come to Dr. Nisha, she'll operate, okay?
No,
So I think we have to, we are all on the same platform.
But in this case, specifically in this case, if she is 28-year-old, sperm parameters are normal, only 4 centimeter endometrioma, 1 year of infertility, trial, and tubal status we don't know. There is no harm in planning laparoscopy. Do cystectomy, check the tubal status, do fulguration of the endometriotic spot, and you can get the better staging of the endometriosis, and then you can plan for IUI or controlled ovarian stimulation. If tubes are blocked, go for IVF also, because she's a young patient, good ovarian reserve, normal semen parameter, nothing like it. If she conceived naturally after laparoscopy, if tubes are okay.
That's why
No,
I
but
said
the chances are quite high that she might not get pregnant.
with it.
Then we can do IVF because
But
she's
then
young
subjecting her to 2 different procedures will be,
Dr.
debatable.
Manju, by the time you do all that, our patients would be pregnant 1.5 months. Actually, we have to go step by step. It's not that we just, as Dr. Nisha, where is she? I can't see it.
Yeah, I'm here.
You're there. I like the way you speak. And very categorically, you have said that, the different cases for different, we have to go step by step. And then she also said that she'll send her back to the other doctor.
That scenario is different, madam. The age is 38
That was
years.
age and low AMH.
AMH is 0.8,
No,
ma'am.
but we are talking. I was thinking we are talking about
Clear
that.
We were very sure. We were very sure. There were clear-cut guidelines. Low AMH, high age.
In that
उसमें तो
case,
doubt नहीं है. इसमें doubt है.
इसमें डाउट है. ये this is the case जिसमें दोनों ऑप्शन हमारे पास अवेलेबल हैं. लेकिन 38-year-old AMH is 0.8. There is no option of.
So you are talking about that patient. Okay.
Yes.
Yeah.
So
What I believe is,
if you ask me about this particular
Sorry,
patient,
no offense. That's why I said ki whom she visit, that will be one of the scenario. So I know that, yeah, but that is a borderline case. That's why I said this, ki whom she visits, sometimes the treatment will be decided accordingly.
yeah, that is true.
So, now this last case, she has recurring, she is nulliparous, married 2 years, and severe dysmenorrhea, dyspareunia. Previously underwent laparoscopic cystectomy long time back in 2019, and it was stage 3. Histopath revealed endometriotic cyst. She received 6 cycles of leuprolide, and then again she got married in 2022, and after a year she presented with recurrence. So we are dealing with a case of recurrent endometriomas, and for which she had a laparotomy diagnosed as stage 4, and now it is bilateral as well. So here again we are at a sort of a loss of to understand now. For recurrent endometriomas, she was counseled to have a transvaginal cyst aspiration and then to proceed with IVF. So now we would take the opinion of our specialists, our panelists. So what should be done in such a case scenario where she has been operated before, and she again comes with bilateral endometriotic cysts, and they are big cysts, and she also has pain, and we are now we are dealing with a case which has pain, which has been operated before, and which needs to be treated for infertility.
First and foremost, we have to see what
The
is her
ovarian
AMH.
AMH must be low, ma'am, because already she has been operated. But ma'am, let me know. Yes, yes.
Very low,
What is
then
that?
we have
Been operated twice,
for,
one in laparoscopy and second
donor
in
oocytes. If it's too low, though she's only 28, right, Jyoti?
Yeah.
No,
I
no,
think this is
definitely
more
a
of
case
a
for IVF.
hypothetical case, ma'am. This was never. I mean, we just want to discuss a recurrent endometriosis case.
Okay. So if it is a recurrent endometrioma and has been operated several times, then definitely the AMH value should be known. And if there are no AFCs and all, I think donor oocyte program is the best for these patients.
By first down regulating her with GnRH agonist, doing long protocol and taking her for IVF will be the choice of treatment probably in her case.
But then if there's no, if the AFCs are not there,
then
where
down
are we
regulation will further
decide by the age, AMH and AFC.
Yeah.
Where we have to go for the self and for the donor. Second is whether we go for down regulation and then go for this one. Then that all depends upon whether the cyst is present or not in this case presently, or there is endometriosis. The surrounding endometriosis patient having pain and all, then we can do down regulation. Otherwise, we can go for directly for antagonist protocol, freeze all the embryos, and then down regulate, and
then trans.
frozen embryo
And the
transfer.
recent thought says that you downregulate after the egg pickup. You first keep the
first-
embryos freeze and then downregulate. Earlier,
Because
people used to have first downregulation ultra long for 3 months. Then they used to have the ovum pickup. But
Very
now,
correct. Very
But
correct.
that requires a long dose of
Because she's
Yeah.
already having
yes.
low ovarian results.
She's
and then
already taken.
further deteriorate.
oocyte retrieval is on the
Then,
further
but
low.
what is the, as you have put already the question, what is the thing? Should we attempt the transvaginal cyst aspiration?
Yeah,
Or
so
should
that
we
is
not?
what, whether
Yeah,
we should be
that's why I
doing
want
that.
to know others'
That is
opinion
another point
also.
of discussion.
If you are going for transvaginal cyst aspiration, then go for down regulation and then start stimulation. If you are not going for transvaginal cyst aspiration, then you can go for antagonist protocol and then retrieve the egg, make the embryos, freeze all embryos, then down regulate and then transfer.
And then that depends on the size of the ovarian cyst also. If they are big, then obviously they will come in the field of the oocyte pickup. So we
Then
must
only
think of,
we can aspirate. But if there are small endometrioma, I'm not obscuring our ovum pickup. No need to do any transvaginal cyst aspiration. And mind you, if you are doing cyst aspiration transvaginally, give a good course of antibiotic. Otherwise, abscess will form.
Yeah, one case I want to discuss. One of my patients, she is having very low AMH of 0.3 mH. We proceeded with she has one endometrioma cyst on left ovary, around 4 centimeter. To my surprise, when I did her OPU, everything went well. We were able to retrieve like 3 eggs only, and day 5 embryos were formed. And after that, I give her down regulation. When we did the follow up, the size decreased. And after 2 or 3 months, we did hysteroscopy, and to my surprise, the size increases, and she has a low grade fever. And she on MRI, because all the investigations were showing that she is having infection, but all her blood tests were like fever profile was done, no cause was not found. Then we underwent with the MRI, and to my surprise, the abscess developed after 2 months of OPU.
Yes.
Yeah, so that was like it came out to be a nightmare for me. I read so many case reports, and they were said it usually present within the 1 month of OPU. But
You have to be
yeah,
extra careful in the ovum pickup of cases of endometrioma, or whether you are doing for a cyst aspiration, endometriosis cyst aspiration, or you are doing an ovum pickup in endometrioma cases, give a good course of antibiotic.
Already
Otherwise, the patient can land up in
IV antibiotics were given after post-op also, and follow-up one was done. Lupride was given, size decreases, and after 2 months, its size increases. And MRI, CT was done. No, nothing was like ultrasonography by radiologist was done. Nobody said it is sepsis. And after
only, we should enter only one time in one ovary, not we are doing it repeatedly. That should be avoided. Repeated entry in the same ovary should be avoided, because this is obviously a toxic blood which is inside the system.
that we follow in all cases. In all cases, pickup, we try to minimize our puncture. Okay.
Yes.
But sometime we need to take, then we can take out to na. We cannot only there are 3-4 follicle. We cannot leave the follicle behind. So sometime we need to take, but the precaution is only don't puncture the avoid that till
I
the
can add to this discussion as far as endometriomas and OPU. We have to be extra careful, and it's an art. It's in OPU is also an art. It's not people say, oh, this is a very easy surgical procedure as compared to the others. But I think technically sometimes it will be so difficult, much more difficult than many other surgeries. And especially when you are doing an endometrium with the endometrioma, you should be knowing how you can go beyond that, and you have to take the support of your assistants. One of your assistant, you have to train them how to do the abdominal pressure. Your anesthetist has to rotate the table and all that, like a drama it is.
Many a times these ovaries are behind the uterus, so it's very difficult to bring them in window.
So when you suppose you will enter in your lifetime, you are going to enter the endometrioma. What you should do, and then you also aspirate oocyte. What you should do, you have to give that test tube with the follicular fluid and the oocyte retrieved, and tell the embryologist, you have to tell your assistant, tell them, keep it separate. It is with an endometrioma. See separately, and then throw that stupid needle away. Don't be conjuice. If you do, then you may end up in a, this what you had, that pus and all that. You have to be, you have to have a third sense when you do all these things, and with lot of experience and slowly, and from the beginning, you have to develop all these things, oh, I have to do this way. So what I have done in all my centers where I have started, even now in the new center, some SOPs you have to create for your OPU, and you create a separate SOP for your endometriosis cases. Then all these problems can be, brought to a real minimum, right? Yeah.
It happened for them, like endometriosis is common these days, but we are dealing it with it, like it came as a surprise to me, because that is the ovary that first we aspirate the normal ovary, and usually we leave the follicles that are behind the uterus, but her AMH is very, very low, that I have to go through that, because otherwise the other option will be donor eggs. That is the last option I can do, but that's why I proceeded with that. I followed her. I told her that I went through your in endometriotic ovary. Patient was informed that why I'm giving you IV antibiotics. Everything's, but it happened after 2 months of opioid.
Yeah,
That
it can happen. Maybe it was a very small thing, and initially when you have given antibiotics and all, it must have not really cleared up. Afterwards, something triggered, her immunity must have gone down, and it has come. And what I do, just some tricks of the trade I'm giving you all, if you think I should. So in all these patients where we aspirate, especially the donors and all, even very small follicles I do aspirate just for my practice. Practice makes a man perfect. So I wish that I want to do IVM sometime. So for that practice, and then it also helps how diligently you can do in these endometriosis cases and all that. And there are so many other, and what I do, I start from always be very systematic. Systematic will really save many times. I always do first the right ovary and then the left ovary. And then another mantra is, you have to go from the lateral to the medial. Can somebody tell me why? Why do we do that? From lateral to medial.
Lateral, because ovary can slip up if you.
I'll tell you. It has a very scientific reason. Because what is there on the lateral sides?
Vessels.
Vessels, right? That is the only major complication that we're scared of. So once the ovaries are filled with these follicles, they're more heavy, right? So we start doing from the lateral to the medial, because supposing we do from the medial, then the ovaries become lighter and they start moving.
Right.
Once we remove all the lateral side, we are not very worried. We are now on the medial side, nothing will happen. So always first to the right side, start from the medial, start from the lateral, go to the medial, then do the left side, start from the lateral, go to the medial. So this is the way, very system, and don't go haphazardly. Go one by one by one by one. And also, there are some people who are not. I always control the suction machine myself. I'm so old, but I don't allow anybody, because that is we may enter somewhere else, like, we may enter the endometriosis. There are so many centers where the nurse is doing, and they're going one by one. All such wrong techniques we should not cultivate. So it's a system, it's a discipline.
What's your take on the flushing of the follicles? Does it help in the recovery of oocytes?
Earlier, yeah, I'll tell you on that. Earlier, I used to think, in 1995 or 96 when I started, but it really doesn't help. It's a waste of time, and you're meddling with all sort of things, putting something, removing something. Again, there may be infection. I don't do that.
Absolutely.
Consuming and more painful.
I would
more
just
time
like to
consuming,
add
and you don't get anything out of it.
I swear, even the small, actually many of them leave this 10 mm, follicles and all that, small ones. I do it because I'm expert in that and for learning purpose I'm doing it. So if you're really got a lot of
No,
experience, you can
it is also a good practice, Dr. Kanti, to remove those smaller follicles also, because
Yes.
I mean sometimes they also do matter. There was I think we'll have a talk by Dr. Surveen Guman. She
Okay.
in her I don't know which conference, and even she has done that study, and in that even that 14-15 mm follicles did provide extra oocytes. So
We
I mean,
get, we do get, we do
yeah,
get.
we do
Yeah.
get. So
Especially in
those,
poor ovarian reserve, they give sometimes. Yeah.
yeah, so we should not leave any follicle unaspirated. As far if it is very close to the iliacs, very dangerous, difficult to approach, then only we should leave. Otherwise, we should make it a habit to remove, to get as many
more
follicles.
small
And so
follicle
even
behind without aspiration, that will more uncomfortable to the patient. Most post-operative pains are also there.
And it
So
can
we
lead
are
to
still in that.
OHSS.
hyperstimulation, right?
OHSS is there.
Right.
If you are transferring, or if OHSS is there, so we try to aspirate even 10 to 12 mm follicles.
Ma'am, one thing I would like to add,
Malik,
if any endometriotic cyst, sorry to interruption, ma'am, please you proceed. Please. You were saying something. Ma'am, I would like to add one thing. I have seen one case in my hospital where I have done my fellowship. There, one patient used to come and she used to have recurrent endometriotic cyst. So my mentor under whom I did my fellowship, he was very well versed in doing the transvaginal cyst aspiration. So I had a learning of doing that. I myself did also in my fellowship days. So nowadays I'm not doing because it is scary and nobody is doing. But he used to do, and one patient used to come and having in her 2-3 years, she had 4 to 5 times cyst aspiration, and never did her biopsy was done. One time she came and she had low grade fever with loss of weight and with all the abdominal symptoms. So we thought in terms of abdominal tuberculosis. So but she did not relieve of ATT. So she was then finally she was taken up for laparotomy. And what we found is that she was turned out to be a case of endometrioid carcinoma. So in case of recurrent endometriosis,
CA-125 was not done?
not done, ma'am. She was actually
very sad, very sad. Yeah.
So that is one thing I learned, that we should have a biopsy at least if she has a recurrent endometriotic cyst. So once in lifetime, she should have a biopsy, and if it's recurrent and systemic symptoms, so she must have thought in terms of malignancy also.
Niharika has given a very good take-home message. Fantastic. And please do the biochemical test. It's so simple. We get so
But sometimes CA-125 gives false reports. In abdominal TB, it's raised also. Sometimes it's come to 250 also. So there is a confusing thing there.
No, but you have to go to a standardized laboratory.
125 is 40, 30, 60. That's
650, 60, yeah.
See, at this point, you know,
I would like to make one point. I don't have a personal experience with this transvaginal aspiration, but all the guidelines now, the protocols are there. There have been good papers which have been published in Fertility Sterility. They say that if you are doing aspiration along with especially sclerotherapy with ethanol, they say that you aspirate the cyst fluid and you send it for cytology to rule out this malignancy, as Dr. Niharika was saying.
Cytology does not reveal much of the things.
Fluid cytology you have to send. The big
And also culture of that
You're aspirating now, that you have to send for cytology to rule out this, and if you feel that this repeated recurrence or any other symptoms are there, then we have to investigate further. So if we are doing this aspiration thing, and particularly recurrently, there have been studies in which they have done this 5 to 6 aspirations also, and they say the recurrence rate keeps on decreasing as the number of aspirations increase, even without the use of sclerotherapy.
So these days,
but you have to send the test fluid for cytology. And second point I would like is that for any if we have this DOR patients and with a endometrioma in situ, if we are doing then OPU, then also prior counseling is very important, because we might inadvertently go through the endometrioma and the patient might land up in this ovarian abscess kind of a thing. So we should counsel the patient that we might leave some follicles behind, and even with all the precautions, a complication might happen. And we have to document all these counseling also. Before also we were discussing about whether to do a surgery first or a laparoscopy first, or go for direct IUI or IVF. So I am basically doing IVF. So what we see is the patients think that they have undergone a surgery and now they will have a natural conception and they don't need to go to the doctor for anything. And they land up after a couple of years to the IVF specialist with a recurrence. So I think counseling, proper counseling, written counseling is the most important thing for all aspects, whatever you are offering to the patient.
One last point I want to say, Dr. Jyoti Malik. We have to, in these cases of endometriomas, endometriosis, adenomyosis, many times adenomyosis and endometriosis goes hands in hand. So it's not, medical management has a big role. Not that I don't like surgical. First, let us give the medical management. And whenever you give the medical management, it is not only one drug regime. We have multiple drug regime. Myself and Dr. Ramani are doing research on 3 drug regime. And we first initially take the volume of the uterus, give the 3 drug regime. After 3 months, again, see the volume, except all that. So you can use multiple drugs. That's what I'm telling, molecules.
What all drugs are you using, Dr. Kanti? What
Yeah,
all drugs?
yeah, GnRH agonist, letrozole, and dinogest.
Okay. And what is the regime?
Yeah, GnRH agonist is per month 3.75, and dinogest is also 1 tablet in the night, and even letrozole 1 tablet. That's it.
Okay.
But measuring the uterine volume and all gives, and it's more successful in adenomyosis cases. And all
what is
my
the cutoff of the uterine volume that you take for this 3 regime, and then how do you taper it down?
Normal uterine volume is around 90, right? 80, 90. So more than 100, we can start this. First, you have to use the single molecule. If it is not going down, then there are selected cases where we use this. And whenever you have to also understand that these cases of adenomyosis and endometriosis do have gut dysbiosis, and you have to give them probiotics. I am a strong believer, and so many of my patients have been benefited, not only giving them medical management that is indicated for them, plus the probiotics you have to give them. And that really helps in a big way. Suddenly they start improving. Sometimes you think, oh my God, why is she not getting all right with the medical management? You have to do everything. You have to make them understand that you have to take. None of my patients say, no, we won't take. We have to make them understand this is the thing. Even in PCOS, I'm giving probiotics. It has a big role. So these are some of the ways that we can improvise our results for the patients. It was such a fantastic panel. Oh my God, I've thoroughly enjoyed, Jyoti. Fantastic. Please call me again.
Wonderful. Actually, you were wonderful, Dr. Kanti.
Your inputs are very
You made such a difference to our discussion.
No, all of them are so nice. Oh my God, I really love all of you.
Thank you.
I wish I was in Haryana, ISAR.
I'm glad I joined.
Welcome.
We'll always include in you in our programs, because you are absolutely amazing, and your actually practical points and the way you've dealt with. That is why we are all still glued, so that so many practical points we've learned from each other.
Thank you so much.
Thank you each one, and thank you our chairpersons for the first and second session, our speakers, Dr. NM sir, Dr. Sujal, for sharing those particular medical and surgical management points for this enigmatic disease. And thank you all, our Dr. Kanti, special thanks to you for being here. And our all the 4 panelists, Dr. Jyoti, Dr. Rakhi, Dr. Niharika, and Dr. Rubina. And thank you, Manju, for moderating such a difficult subject so nicely and so coolly. And thank you, Dr. Nisha, for staying with us
Thank you.
till the last. And always, you are always, as Dr. Kanti, you always also add your practical tips, and they really matter to each one of us. So thank you, Dr. Gurneesh. I can still see you there. And thank you, Dr. Mandy, ma'am. You आपके बिना हम चल ही नहीं सकते आगे, तो हम आप तो चाहिए ही चाहिए हमेशा.
I like the flying kiss that she's giving.
Yeah. So thank you, Nimisha. Thank you, Jagsonpal, for giving us the opportunity to learn again so much from each other, from our seniors, from our friends, and from our colleagues. Thank you so much.
Thank you.
Thank you, everybody.
So thank you everyone
Thank you.
for
Bye-bye.
this insightful session and for the attendees joining for today. The session was brought to you by Jagsonpal Pharma, the makers of Endorec, Divatron and Maintain injections. So as discussed, Endorec is micronized Dynogest 2 mg in endometriosis associated pelvic pain and during IVF procedures. And we have advantage with calendar therapy pack. Next, we have Divatron 10 mg tablets of didosterone to improve compliance and enhance outcome. And lastly, we have Maintain injections in 250 and 500 mg of 17-alpha hydroxy progesterone caproate for the positive pregnancy outcome. So once again, very thankful to dear faculties, and we look forward for you for participation in the next webinar.
Thank you.
Thank you.
Thank you, everyone. Have a great day.
Bye-bye.